Success.
Very good. Well done. Nothing like a little practice, I guess. By the year 2027 will be great. I just picked a random year. Okay, do we have Department of Health back with us? I see Mr. Fuchs's and Mr. Johansson's rectangles and Mr. Springer.
Yes, Madam Chairman, this is Stefan Johansson. We're ready to go when you are.
All right, I believe we're ready.
Okay, well, members of the committee, again, Stefan Johansson, Deputy Director for the Wyoming Department of Health. Appreciate the opportunity to testify on a few items that you've requested. Madam Chairman, I think it might be most useful if I briefly go over the department's first round of budget reductions that were recently implemented, and happy to answer any questions. And then we can go over the Medicaid minimum requirements for match and various MOE issues. I think those would dovetail nicely, but happy to reverse that if you would prefer.
Nope, that seems good.
Okay, very good. Thank you. So, Madam Chairman and members of the committee, what I'll briefly summarize and then answer questions that the committee might have is a document that we sent out about a month ago. It looks like this, Biennium 21-22 Budget Reduction Plan. It was sent out via the LSO recently, last week, as part of your committee materials, but we also shared it with the committee chairman back in its original release date. That's the document that I'll be going over today. So just by way of background, Madam Chairman, again,
excuse me, Mr. Johansson, let me just say, so members, if you have your giant packet up, I believe we are working off page 190 of that large PDF.
Thank you, Madam Chairman, and God bless you all for dealing with all of that paper. Page 190 does not sound very good. But just by way of background, Madam Chairman, I did want to reiterate to the committee that this, per the governor and the budget office, is part of a three-step process. Step one, back in the spring and early summer, was really a freeze on certain types of contracts, new contracts, a freeze on certain types of position recruitment. That was known as step one. Step two, per the governor and the budget office, was what folks have been referring to as the first 10% general fund reduction for the agencies. Our agency, the Department of Health, as well as a couple of others, were actually directed to implement a 9% budget reduction, which is what you will see in this budget reduction plan. So when you think of, when folks say the first 10%, just know that for the Department of Health, our first 10% was actually directed as a 9% reduction. So just a little bit of background information there. As you can see on the first page here of our report, and I don't know if it's showing up very well on the screen. I'm happy to blow it up if it isn't. But you can see kind of a summary here that we put together, where in the bottom right-hand column, you can see that we reduced just over $89 million of general fund. That represents a 9% general fund reduction for the Department of Health. In our what are called step three budget reductions that are under consideration right now by the governor's office, a 10% reduction equates to about 98, a little over 98, just under $99 million. So with the Department of Health, obviously you're all aware we're talking big numbers at a 10% reduction. But what we tried to do here, Madam Chairman, is really take a lot of the nitnoid detail, which, you know, our budget and our programs get so complicated, and really show our decision makers that we made cuts across all 5 of our divisions, and in what we distilled into 4 kind of discernible categories: administrative type reductions, contracted service reductions, so think 900 series consultants, things of that nature, and then program eliminations as well as program reductions. And you can see that broken out before the total by the divisions that are listed on that second row. So AGD is Aging Division, then Behavioral Health, Director's Office, Healthcare Financing, and Public Health to get to our total. You can see our total general fund budget for the 21-22 biennium is $989.8 million. Bear in mind, our total biennial budget with all funding sources is just south of $2 billion. So about half of our money with a little more represented on the federal side, but about half of our funding is general fund. So you can see how it's broken out across those different categories. And then in addition to the 89 million of general fund that has come out of the 2021-2022 budget, we estimate an accompanying loss of federal and other funds of about $48.9 million. You all know that when we make reductions to our Medicaid program, that generally comes with a 50-50 match. So we forego the federal funds that would accompany those expenditures on the general fund side. In addition, we provide some estimates across these categories of any potential loss in federal funds due to maintenance of effort compliance. And I'm happy to answer any questions or get further into the details there. So again, we were directed to make an $89 million, a little bit more, but an $89 million general fund reduction. And what we did, the second thing I want to point out, we worked as hard as we could, especially because of the complexity that came this year with COVID-19, to identify one-time savings or alternative revenue scenarios that could help us bridge the gap over this crisis period, especially when it comes to the pandemic, to reduce the general fund standard budget reductions that would happen, which generally come in the form of provider reimbursement rates or contracts, money that goes out to our communities across Wyoming. So on the second page of this report, Madam Chairman, you can see that broken down into what we're calling one-time savings and revenue increases. And on the general fund side, that totaled about $23.67 million. And most of that came from our ability to leverage the enhanced match rate that we are still getting from CMS because of the public health emergency. And that's a 6.2% FMAP increase that lasts basically the duration of the public health emergency. Once the national emergency is rescinded, then it essentially, that quarter that it ends, that will terminate the enhanced FMAP rate. So we're able to realize essentially some projected reversions that we would have in our budget. And we worked with the governor's office and the budget office to be able to leverage that, again, to minimize as best we could the impact on our communities, while we know we might have to cut further, as Co-Chairman Scott has mentioned, coming up in the upcoming session, depending on our revenue situation, we did feel like it was necessary to try to minimize it as much as possible. In addition, we are going to issue an emergency rule on the vital records side to increase our fees for various certificate requests, birth certificates, death certificates, et cetera. We still are relatively low compared to the regional and national average on those fees. So we will be issuing an emergency rule to increase those fees by generally $5 across the board for the certificates, and we think that can generate an additional $500,000 of revenue. In addition, we, as you can see there in the Title 25 area, we are planning a per diem rate reduction there effective January 1st that we believe will generate $750,000 in general fund. We are working on the implementation of that and have communicated accordingly with the various providers that provide that service. And last but certainly not least, I know some folks on this committee and others were excited session before last when Senate File 150, or the Health Innovation Studies Senate file, was passed. That gave the department $1 million to pursue or award innovative studies or programming for reducing long-term care costs, increasing remote health service capabilities, a variety of goals that were articulated in that bill. I'm sad to say we did eliminate that or suspend that program and revert those general funds as part of the budget reduction package. So that was also included in this alternative or one-time savings scenario. Those funds for the Senate File 150 innovation studies, those were set to sunset on I believe the end of this biennium in 2022, but we did preemptively suspend or eliminate that program. And finally, some minor contract service reductions at the Life Resource Center in Lander, things where we could leverage some efficiencies with food service, as well as various providers that we contract with, because over the past 18 months, we've been very successful at that facility and at the state hospital in improving our recruitment and retention rates, primarily with nurses and CNAs. We are able to eliminate some of our outside provider 900 series contracts. So taken all together, Madam Chairman, we did about a $65 million general fund cut, plus this $23.7 million in one-time savings or alternative scenarios to reach that total 9% cut target of $89 million. And I'm happy, Madam Chairman, to go into the details of each division, but I might just close here and then answer questions as they arise. We've put this in front of the committee many times before. I know it's probably very small on your screen, but this chart really shows for this round of cuts, as well as any potential further future rounds of cuts that we have to make given our revenue situation. This chart really shows where the money is. And 91% of the department's general fund dollars are really found in 5 program areas. And I will blow that up here. You can see in that top kind of bucket, that top row, it's Medicaid, which includes our waivers, our mental health and substance abuse programming, that's our community mental health and substance abuse centers, developmental preschools, the state hospital, and the Life Resource Center. Those 5 program areas account for the vast majority of our general funds. So you probably heard it discussed at the Joint Appropriations Committee over the past year. It really is impossible at these kinds of numbers with 9%, 10%, 20% cut targets to not substantially affect those top 5 program areas. And so that's what you see across much of our step 2 reduction package. Final thing that I'll point out on this chart, Madam Chairman, is that with the state hospital and the Life Resource Center, as you all may recall, we testified earlier this year about this, and certainly during the last interim and during our budget hearings, we have relatively exempted a few areas of these top 5 program areas, which causes us to have to reduce further or harder in other areas, which is unfortunate. But I wanted to explain a little bit of the logic there, and it really has to do with the behavioral health continuum. And I'll start with the state hospital and Life Resource Center. The reason you see in our cut package relatively minor, in the grand scheme of things, minor reductions is because, number one, the investment the legislature and the state has made in those 2 facilities to reconstruct them, but also remission them, as well as our staffing plan that we developed last year and in the previous session to increase the capacity there with the new buildings. It really relies on a lot of internal funding that the department moved around to be able to staff it at full capacity. We originally requested in our original budget last year a $17.2 million appropriation on general funds for staffing. The Joint Appropriations Committee somewhat laughed at us when we brought that in. So we hit the drawing board and we went back to see what could we repurpose internally in terms of positions and in terms of funding. And we moved over about 20 positions internally from other areas of the department to those 2 facilities to be able to fund them. And in addition, we essentially promised and have set up the financing mechanisms where the Department of Health will have to realize efficiencies in other cost centers to be able to keep that staffing plan sustainable. And those areas are, we anticipate a significant reduction in Title 25 costs by nature of really nailing our new missions at those facilities and scaling up our capacity, reducing our average length of stay in Evanston, a variety of measures that we really think we can see a significant cost offset in Title 25 by nature of this investment. Secondly, because of the new facilities and the elements of those facilities, we anticipate a significant reduction in outside medical cost and contracted labor costs. So the reason I bring that up, Madam Chairman, is because it's very easy, and I understand it, especially from an outside observer, to say, well, you cut so hard in certain areas like Medicaid, the developmental preschools, and just spared your own facilities. And I wanted to put it on the record that there was a kind of a method to the madness of why we did that, because of the investment that the state made and because of the significant cost reductions that we anticipate if we can really operate those facilities as they've been intended. The second area where we worked with the governor's office pretty heavily on that behavioral health continuum was to, with a few exceptions, somewhat exempt the mental health and substance abuse program areas. And that was really because of the work that this committee, the Mental Health Substance Abuse Subcommittee, the Judiciary Committee, and the Joint Appropriations Committee are doing to look at that continuum, look at the funding in that system. And we felt that it would be premature before there's some finalization to the initial rounds of work that the committees and the executive branch are doing to really significantly cut that system until we see maybe where we're going. Now, a subsequent round of reductions, obviously with a line item that large relative to the department's budget, it's probably unlikely that we would be able to avoid those those areas to reduce in future rounds of cuts. But I did want to make it clear to the committee that to avoid across the board reductions, which was certainly on the table, but ultimately directed by the governor, and I think very positively directed by the governor, to not just go across the board and try to be strategic in the cuts that we were making. So, Madam Chairman, happy to stop there and answer any questions, or if it's in your purview, if you'd like me to go into the details on each division, happy to do that as well.
Well, we might be more efficient with questions. Members, while this plan is still up, I can't see all of you with your hands. So use your, oh, there we go. Okay, who has questions for Mr. Johansson? Senator Scott.
Madam Chairman, first question is on the developmental preschools. I was unable to correlate between the various slides as to how much you'd actually taken out of them. So I'm interested in what that was. And I have a further question. Was there any consideration given to the amount of increase that was going to cause in our spending for K-12 special education? Because there is a direct trade-off there of some magnitude.
Mr. Johansson.
Madam Chairman, thank you. And Co-Chairman Scott, to answer the first question, the reductions to the early intervention, what used to be called the developmental preschools, for this first round was $8.82 million. And that is across both the Part C, which is birth through 2 years old, and Part B, the 3 to 5 year old. Both programs combined was about $8.8 million. Give you a little bit more detail, Co-Chairman Scott, across on the Part B program. You'll remember from previous testimony from the department, we have over the past 2 to 3 years, we've seen a somewhat significant reduction in the identification rate in the Part B 3 to 5 year old program. So we did have budget flexibility within that program where, essentially the funds have been and we projected would revert. So on the Part B side, we anticipate in this first round very little, if any, actual contract reductions. Essentially, we're scraping some of the excess budget out of that program. That's not the case, as you're probably aware, with the Part C birth to 2 year olds, where we will see about $4 million of contract reductions in that program. So that all in all, average between the two cost centers, it represented about a 13% general fund reduction. And to your second question, I'll kind of take it in two parts. We do estimate, or we have estimated in the past, that it could put us into maintenance of effort compliance issues. In 2017, 2018, when we cut these budget units, we did project a loss of federal funds that ultimately was not realized. And so we can, for at least a year period of time, we can waive out of the maintenance of effort issue if the state is facing significant budget challenges, which obviously it is. And so we're in discussions and actually just had a discussion today with the governor's office about being on the same page with the risk of the loss of federal funds. To your last question, Senator Scott, in terms of the cost that we anticipate may increase in the K through 12 system, I won't try to candy coat it. I don't know. I think that's certainly a reality, given that part of the mission of these programs is to prevent certain special education costs there, but we don't have a great way to quantify what that might be. So I think that's an inherent risk in cutting a sort of preventive or early intervention program, but I don't have a solid number for you on what that might look like.
Senator Schuler.
Thank you, Madam Chair. I'm just wondering, you talked a little bit about moving some positions around to try and reduce costs. And I just wondered if maybe those were some of the traveling nurses that we sometimes have to deal with at the Life Resource Center and the State Hospital. Thank you.
Stefan.
Madam Chairman, thank you. And Senator Schuler, you're right. One clarification is those wouldn't be state full-time equivalent positions. What we're really looking to do, if we can, and as we continue, we have improved, and I'm optimistic as we continue to nail that staffing at those two facilities. I'm optimistic that we can reduce our reliance on the kind of contract labor that you just mentioned with, traveling nurses or any of those agency nurses that we or others that we contract with. In terms of the actual state positions, we had moved positions that were either vacant or had been vacant for some time from the department over to those two facilities to be able to, in essence, beef up our state staff. But again, with the hopes of having those downstream effects for our counties, for our courts on Title 25 wait lists, Title 7 wait lists, which all have costs that are borne in your communities. So we won't see those savings accrue likely for another year and a half, especially as we await the opening of the new Life Resource Center later next year. But once we have those two facilities hopefully operating at full steam, again, it's not just an empty promise. We have set up our financing with the legislature by financing it for this biennium internally, essentially, we are committed to those cost reductions. And I think it'll be easy to hold the department accountable for that, because if we don't hit it, you'll see a budget request.
Chairman Scott, did you have a follow-up?
Well, yes, Madam Chairman, I have a separate question. That I am very deeply concerned about the preschool cut, because I think we're going to have to make it up in spades that it'll cost us more in special ed than we're saving here. But that's a whole topic unto itself, and I don't want to take up too much of the committee's time on it. But that's an issue we're going to have to consider during session. And look for some other places. I have a further question. Did the health department consider closing the Pioneer Home and the state nursing home?
Steph.
Madam Chairman, Co-Chairman Scott, I believe I heard the question on if we considered closing the Pioneer Home and the retirement center, the nursing home in Basin. I'll answer that somewhat delicately, that yes, those options are always on the table, and it was a recommendation early on in 2015, I believe, from the Facilities Task Force to study the privatization of the Pioneer Home. We were not directed to do that. We did discuss it as options with the governor, and I'll take them kind of separately. With the Pioneer Home, that is, the budget is a little bit misleading. It shows, I believe, about a $5 million biennial budget there. The actual state general fund subsidy is around $2.5 million because of the revenue that's collected. And it's about 49 full-time positions that are in the budget. Ultimately, Senator Scott, we did not put that forward as an option because it has been discussed year after year as an efficiency, an option, and it really has caused some morale issues on our side, on the management of the facility, and ultimately that was not considered. We were not directed to make that part of this first round of budget reductions. Whether it's considered in the upcoming session, I think that's remains to be seen. But we are operating that facility as a going concern. Very proud of the performance of that facility. But certainly, we looked across all areas of our enterprise to identify the general funds that could be cut. With the retirement center in Basin, Senator Scott, it was not on the table for reductions, and the real reason for that is for the past 3 years or so, we have operated that facility at a revenue neutral position. So there is no general fund subsidy there, and really the only savings that would be realized would be major maintenance and depreciation.
Or questions for Mr. Johansson? Representative Yin.
Thank you, Madam Chairman. Mr. Johansson, I'm looking at the budget cuts, and my question is, will any of these cuts affect how we respond to the current pandemic crisis that we have now, especially given our CARES Act funding will run out by the end of the year, and it seems, at least for the next month, it is unlikely we'll get another relief bill. So what does that outlook look like for the next year and going forward?
Mr. Johansson.
Madam Chairman, thank you. Representative Yin, the really easy answer to your question, kind of in terms of direct funding, is no. We did not cut areas of the department that are primarily responsible for the pandemic response for obvious reasons. So the public health lab, our epidemiology staff, systems that support our response were not identified for reductions. And a lot of those areas do have significant federal funds already in the budget that didn't really make them a high value target, for lack of a better term. In terms of the indirect effects of budget cuts during a pandemic, I think that's certainly a consideration. Something that keeps us up at night is when you reduce reimbursement rates for providers, when you reduce contracts that we have to do. Again, there's no easy way to put it. We just have to make these reductions because the numbers are so daunting. Those indirect effects, Representative, could certainly be there in terms of access to care or other indirect consequences, but nothing kind of directly on the funding side will impact our response. And to your second point about CARES Act, state local government CARES Act funding with the end of December spending deadline, we don't know yet if that deadline will be extended or if another package will be passed by Congress. I think that's always kind of a sit and wait approach. But we have developed kind of a comprehensive plan. We've been, for the pandemic response, the department has been using those dollars wisely. I believe over the past 5 months, we've obligated about $57 million of those funds and used them to support human capital and services at the public health lab, third-party, saliva-based testing contracts, wastewater sampling, a number of areas that we do have. Probably not perfect because there's so many unknowns, but we have a sustainability plan that will take us not only through the end of the year, but as we anticipate that we'll be somewhat in pandemic response into 2021 and throughout 2021, we will be leveraging other funding sources that were separate from the state and local government CARES Act, but came from other pots of the CARES Act that we will transition to keep those efforts going.
Representative Hallinan has been waiting patiently.
Thank you, Madam Chairman. The Substance Abuse and Tobacco Prevention Unit, is that broken down into 2 separate units, one of them for substance abuse and the other for tobacco prevention?
Mr.
And if
Johansson.
it is, how are they broken down? How much money for each?
Madam Chairman, that unit does include substance abuse prevention and tobacco prevention. I will follow up with you all and Representative Hallinan on the specific breakout. I don't have those numbers in front of me.
Thank you.
Okay, more questions? Representative Sweeney.
Thank you, Madam Chairman. Stepping back on table 5, on the second line there, 2.5% reduction to most provider rates. So some of the existing base rates, my understanding is, didn't meet costs a lot of times. And so does this just further amplify putting some of our contractors deeper in a hole, in your opinion?
Madam Chairman, Representative Sweeney, there's no doubt about it that it's obviously a further reduction. These cuts, take any one of these cuts, we certainly didn't want to do them, and it has a negative financial impact on the providers. I will mention, and we'll talk about it, sir, here in a bit with the Medicaid presentation, that our strategy as a state and certainly as a department has been to do the best we can to pay adequate rates. Now, obviously, there's limitations to that, especially with federal law and your upper payment limit. But we, compared to the region, do pay relatively well in Medicaid, emphasis on relatively, which is why I think we have one of the highest provider participation rates among physicians, among other provider types that accept Medicaid patients in Wyoming. But that 2.5% reduction in this first round, one of the reasons we worked with the governor's office to leverage those one-time savings was to keep that from being a higher percentage reduction. But Representative Sweeney, you can see just based on the raw numbers there, those types of rate reductions, it's such a big part of our enterprise that, again, at these levels, we have to strike the balance between full-scale program eliminations, of which we have some in this plan, unfortunately. But we have to strike that balance between, do you eliminate full-scale programs, or do you have a combination of where you can reduce rates and reduce contract expenditures to be able to hit this target? So we'll get in a little bit to kind of what payment means in terms of access, but I will say we do monitor heavily, especially on the Medicaid side, and so does the federal government, by the way, that if certain cuts are made that get us to a tipping point of where providers might drop out, where access might not be sufficient for Medicaid beneficiaries, there are certain federal scrutinies that will be applied on what's called an access review monitoring plan, where we do have to, as a state participating in Medicaid, ensure that we have at least a baseline sufficient access for our members. I don't think we'll trigger that point with this reduction, but again, we're all monitoring it very closely with the revenue situation and further reductions we might have to make.
I think I saw Representative Yin's hand up.
Madam Chairman, thank you. Mr. Johansson, I'm wondering how soon. So right now, it doesn't seem like we are cutting that many federal dollars out by cutting with the current cuts. And so I think my question is, how soon do we start losing significant federal dollars with every new dollar that we cut?
Chairman, Representative Yen, it's a mixed bag. So for most of our Medicaid reimbursement rate reductions, it's essentially a match kind of system. So those dollars we just won't see. So again, it's a little bit nuanced, but I think it's helpful to consider that somewhat immediate. From a budgetary perspective, that those estimated federal dollars are out of our spending authority. But obviously that's not kind of the operational perspective. So with Medicaid, that match, when we don't spend those dollars, when we reduce rates, or when we put utilization controls in, et cetera, those dollars are essentially just not going to flow in. In other areas, like I mentioned before, time will tell of what federal funds we lose, because when you talk about maintenance of effort, and a good example is the developmental preschool program, that kind of operates on a lag. So we'll have our child identification happen this November and December, and essentially we will find out if we triggered maintenance of effort issues over the next federal fiscal year. And so it's kind of a mixed bag, Representative, where some of it is immediate and others take a bit of time to determine what, if any, federal funding we'll lose, which is why we always, in the budget proposals, try to note that these are estimated losses.
Representative Sweeney.
Thank you, Madam Chairman. So I'm kind of slow on the uptick here. Child development centers is what part of the mission on those funding losses. Is that correct? Is my first question.
Madam Chairman, Representative Sweeney, when we talk about the child development centers or developmental preschools or early intervention programs or EIEP, that all means the same thing. That's in Unit 2510 of the Behavioral Health Division. Those are essentially state general fund dollars and some federal Department of Education dollars that flow to about 14 regional child development centers across the state to provide early intervention education services for birth to 2-year-olds and 3 to 5-year-olds prior to entering the K through 12 system. So I don't know if that answers your question,
Yes.
sir, but happy to elaborate.
Representative Sweeney, did you have a follow-up?
Yes, thank you. And then that gives me a better understanding. Thank you. And so I'm trying to understand the numbers again. So our total for the biennium estimated on Medicaid reduction would be 46,550,000 for the biennium, or 23 million and change for the year. And so to get the total cuts for the biennium, would you take the 95 million plus the 46 million into consideration? Is that how the governor's cuts were taken into consideration?
Mr. Chairman, Representative Sweeney, that's a good way to look at it. Just a small clarification that from a budgetary perspective, a state budget perspective, it is kind of looking at the full biennium that started last July 1st. From an operational perspective, obviously with various contract programs since July to the time that we implemented these last month, we did pay, July payments, August payments. So that money was spent. We do not go and claw that back from the providers. So the best way to look at it, Representative Sweeney, is if you take the general fund reduction that we made, which is 89 million, that you can see on table 1 there in the bottom right-hand column, that's our 9% reduction, and then add the 48.9 million as the accompanying loss of federal or other funds. That's what gets you to our total budget reduction for the 21-22 biennium. And I will mention that all of these cuts, including the one-time savings and revenue increases, these are all part and logged into the standard budget. So that will continue into 2023, 2024 when we get to that time. But we anticipate, again, with some of these one-time savings, the 6.2 match increase from the federal government because of COVID-19 might not be there, likely won't be there into 23-24 biennium. So a lot of that will change in the standard budget when we start developing the next. It's crazy to think we'll soon be developing the 23-24 budget, but we will, in the early parts of next year.
So in reality, Mr. Johansson, even if you didn't have to do a step 3, the subsequent budget would be lower because you will be missing the CARES Act money and that sort of thing.
Madam Chairman, I think yes, but I would say that again, that wouldn't be, the CARES Act funding wouldn't be considered part of our standard budget. So that's something that,
right.
yeah.
I'm speaking sort of loosely rather than in an accounting term, but as far as money that people see going out. Yeah.
Yes, absolutely correct.
Okay, more questions for Mr. Johansson. Representative Sweeney.
Thank you, Madam Chairman. So back to table 1, Stefan, on the administrative reductions, because there's a radio personality that's heard in Casper and several major cities that's a self-professed expert in a lot of these fields. But he just talks as though it's easy enough to eliminate all these positions and all these jobs to shrink the size of the state budget. But if in particular on that administrative line, that's 6.2 million. And that's a biennium figure. So 3.1 million per year. How many jobs will that affect, which are our neighbors? And that affects the economy also.
Madam Chairman, Representative Sweeney, we did have kind of an overt effort in developing this first proposal to minimize our reduction of full-time employees here. And that was not to, keep, administrative bloat going, but that was kind of to your point, and a little bit of background, if I may, Madam Chairman, that it's helpful to remember that 90% of our budget goes out to, in the form of reimbursements, contracts, et cetera, to providers, to local organizations, businesses, et cetera, around Wyoming. And so if you look at the structure of our budget, a claim like that we could eliminate, all of our state staff or our Cheyenne staff, we wouldn't come close to the $90 million even if we did that, eliminated every employee that we have here in Cheyenne as a program manager. That wouldn't get us close to our target. And the reason for that is out of, 90% goes out the door to communities and providers. Of that 10%, which is a significant amount, that goes to overhead, staffing, et cetera, the vast majority of that 10% is located at our 5 healthcare facilities around the state. So our state hospital, our Life Resource Center, Pioneer Home, Retirement Center, and Veterans Home. That's where our people are. And I mentioned before that we did not make significant reductions or staffing reductions to the facilities in Evanston and Lander, and I won't go over those reasons again. But that's what I would say, Representative Sweeney, is again the structure of our budget doesn't facilitate an easy reduction, an easy cut when you're talking about $90 million, $100 million to just eliminate staff. There are some staff positions that we eliminated. We eliminated one in my policy shop here. We eliminated one in the fiscal shop. We did look at administrative reductions, as you can see, whether it was various contracts or support services or consultants, and that's why you see that $6.2 million figure there. It was again a targeted effort to see where we did have some administrative expenditures that weren't absolutely necessary. Going forward, as we all know that the legislature might have to consider, we might be directed to do a second round or the step 3, as it's called, for another 10%. It is very difficult for us to not have staffing impacts when we talk about these numbers. But again, it's difficult because of the structure of just how much money that is in our budget that just goes straight as contracts or reimbursements to your communities. That's really where the majority of the money is.
Thank you, Madam Chairman, and thank you, Stefan, for those clarifying. A little bit of revenue would go a long way, I think. Thank you.
Questions for Mr. Johansson? So I have a couple. The first is just several years ago, I ran a bill to raise some of the vital records fees and put it towards IT expenses at the Department of Health, and it didn't pass. I couldn't get it out of the Senate committee, but my recollection was that the vital records fees ended up going to the general fund. And I thought, and we had some inquiry yesterday, I can't remember even what it was about, where the money, I guess it was on the admin for the Medicaid programming when we were looking at the upper payment limit. So back on your revenue raise, increased charges for vital records, is that somehow cycling back to you, or do you need a statutory move, or Or is that going to the general fund?
Madam Chairman, that's a great question. I believe that does go back to the general fund, but I will double check on that to make sure that operationally or mechanically we don't need an account to be able to capture that. I don't believe that we do, but I will clarify. And then just to your point, I do remember that bill. I do, and some of the revenue from Vital Records does get diverted to the Children's Trust Fund to pay for certain
Right,
things.
it's
So,
like the top
there-
$5 or something, but the
right,
rest of it,
there's a few tributaries that those revenue dollars take, but I will confirm to make sure we don't need any authorization to be able to capture that, but I don't believe that we do.
yeah, and I'm not entirely sure of that. So then the other question, and I kind of complained earlier about people who want to cut the state budget except not their program. So I hate to, now I'm doing it. I'm not really doing it because I see your problem, but I want to, the part of the discussion that Senator Scott had with follow-on costs to special ed from cuts. Some of the cuts in the aging area to the PACE program and to the home services on the waiver folks. I trust you folks to have tried to make sensible reductions, and I know from my time on appropriations that sometimes you just don't have the money, even if it's going to cost you more in 5 years. But could you talk to us a little bit about kind of the balancing act there? Because my assumption was that both the PACE program and the home services would keep people at home and out of the nursing home, probably costing Medicaid money.
Madam Chairman, great questions. I'll take the Wyoming Home Services Program first, and just for the committee's reference, that's on page 7 of the report that I was, so that would be page 197 maybe in your materials. But page 7 of our budget reduction plan does show the phased in elimination of Wyoming Home Services. You'll notice there that really accounts for 1 year of the biennial budget of that program at $2.7 million. So that program is about $5.5 million biennial budget. And just to clarify for the committee, that is not an elimination of the long-term care waiver. This is a general fund program that was set up years ago, kind of with a similar mission, but before the larger expansion of the long-term care waiver in Medicaid. So this essentially operates through senior centers, and it's really for folks who may not qualify for the Medicaid long-term care waiver, and provides kind of a lighter array of services. But Madam Chairman, to your point, with the mission of preventing premature institutionalization. So again, this is one of those cuts we certainly don't want to make, but it's a general fund only program. It's relatively small in the grand scheme of long-term care, home and community-based service budgets. Just to give you a comparison, the long-term care waiver, I believe, has north of a $100 million biennial budget with that federal match, and provides a more comprehensive array of services. But we certainly didn't want to eliminate this program, and that's why we have phased it in, if not to generate some discussion about it, but also to ease that blow on the providers and the clients that do either provide or receive services from this program. But I did want to clarify that is not the elimination of all of our home and community-based services for the elderly. That would be a fool's errand given how many times we've presented on that problem to this committee. And Madam Chairman, remind me, PACE, excuse me. We will be eliminating the PACE program. I believe there's a federally required 6-month phase out. And for the folks who might not be as aware, PACE is Program of All-Inclusive Care for the Elderly. It was set up as a pilot project, again, similar to Wyoming Home Services, kind of before the larger expansion of the long-term care, or what we call the Community Choices Waiver in Medicaid. It only serves clients in Laramie County. About 130 clients. And again, with that mission of providing kind of a managed care approach to providing all-inclusive care, again, to prevent premature or institutionalization in general. I want to be clear on the record because I'll probably get some good calls and emails after this. This is really a program that I know personally speaking from my own family experience is a desired program. They're very popular, but we did look at again state general fund only programs and state general fund heavy programs that don't really, from a state perspective, serve a lot of clientele. And it really caused some hard decisions for us to make. In addition, our analysis that we provided to the Appropriations Committee earlier this year, we estimated that based on acuity levels of PACE members, long-term care waiver members, and nursing home members in Medicaid, that roughly 10 to 15% of PACE members may require nursing home level of care if the program were eliminated. Now, I hope we're right about that. If Madam Chairman, to your point, if we eliminate a program like that or Wyoming Home Services and every one of those clients immediately admits to a nursing home, we will see those costs on the Medicaid side. But we're reasonably confident that we'll have services in place through the long-term care waiver to be able to absorb some of those service needs. But it's certainly not perfect.
Well, and I do just want to say that there will no doubt be more painful, undesirable cuts to come. So there's not a lot of good answers in this situation. If we had a whole lot of wasteful, useless programs around, we would have cut them long ago. Okay, any more questions for Mr. Johansson? Representative Sweeney.
Thank you, Madam Chairman. Quick question on the prevention management, those monies going back to the counties, and then a lot of counties have done their Department of Health to relied on them through the county commissioners. Was any of that cut, and where would I find that on these sheets?
Madam Chairman, Representative Sweeney, to my knowledge, and I should be confident about this, but I will double check to make sure, we did not reduce any of that funding. In Unit 550, I believe we did have a reduction in 600 series general fund to the tune of about $200,000, if memory serves, and I'm trying to flip and find it. I believe that's on page 7, the second line of table 7. But we did replace those with other funds, I believe, tobacco settlement funds, so there should be no impact there.
Okay, thank you.
Representative Stivar, I think I saw your hand up.
Yes, Madam Chairman. Just want to get clarified. You said 10 to 15% are going to need continued care from the PACE program or long-term?
Madam Chairman, Representative Stivar, I think, let me clarify if I misspoke. Based on acuity scores, we estimate that 10 to 15% of those members in the PACE program may require nursing home care just based on their acuity scores, but not necessarily will enter a nursing home. So I think it's safe to say, Representative, that all of those clients, when that service ends, will go somewhere or need services, but we think likely upwards of 90% may seek services, home and community-based services, through the long-term care waiver that is available in this county as well.
All right, thank you.
Okay, any more questions? Okay, then, so that's the budget. Then let's see, what do we have next? The maintenance of effort and all that sort of thing, I guess.
Oh, there we go. So we'll go very briefly through this presentation. What you see on my screen right now, members of the committee, is a white paper that we sent through the LSO that goes into way more detail on the questions that were asked about general requirements for Medicaid, including maintenance of effort, match requirements, optional services, required services. So we won't go into all of that here, but we did provide it in more of a long form paper. So if you'll indulge me here, in terms of Medicaid, spending in general, there's really three ways. We've showed this to you before, three conceptual ways to cut the budget in a program like Medicaid. And that's really across enrollment, utilization controls, or reimbursement rates. That's really those three prongs kind of develop our total cost. And when we look at rate reductions, just to summarize some of the things I mentioned before, this is really the most flexible and also the most immediate way to reduce the budget in Medicaid. And like you saw, we're currently implementing a 2.5% cut to most provider types. Some exemptions there because of federal rate setting, et cetera, and with a few caveats. But with not reading all of these slides to you, and in the interest of time, we did learn from 2017, 2018 that provider rate reductions, while it's something we certainly don't like from a policy perspective, mechanically and operationally, it's one of the most nimble ways to cut a large budget like Medicaid. And like I mentioned before, Madam Chairman and members of the committee, these rates affect access. So you can see kind of a visual here that shows when you look at the kind of fee index of Medicaid to Medicare, how we compare, and also our provider participation rates on the vertical graph there, you can kind of see how Wyoming compares to other states. And that square dot up there on the top right-hand side of this chart kind of shows you where Wyoming is compared to other states. And I believe that that poor, sad dot in the bottom left, I think, is New Jersey, in terms of what their rates in Medicaid look like and how it affects their access. So there certainly is a relationship there with how rates affect access for Medicaid members, and it's really driven by what you pay is what you get, and how many providers participate in the program. It's nice to see here that, again, we know that there's often complaints about our rates being too low, and we're certainly sensitive to that. But you can see how we compare to other states that, relatively speaking, we've tried to maintain this strategy that is as best we can, knowing our limitations with Medicaid budget and federal restrictions on reimbursement, that we have been able to guarantee better guarantee access for our members. I did want to mention that CMS does review rate reductions beginning at a 3% reduction, and then closely reviews rate reductions at the 10% level. I believe recently, and don't quote me on this, but due to significant budget shortfalls in the state of Oklahoma, they implemented significant budget reductions, I think to the 10 or 15% rate reduction level, and probably generated a lot of federal attention, like I mentioned before, with how that affects access for those members. Madam Chairman, if I may, I do want to hand this over to Jesse Springer to kind of take over. We just have a couple of slides. We'll go through them very quickly because I know Co-Chairman Scott said he had several questions. Like I mentioned, we did provide this information in the white paper, so we don't have to read these slides to you, but I'll let Jesse just very briefly go through what some of the categories of services are, as well as in the Medicaid program, what is listed as mandatory and optional. So Jesse, if you're available, I'll work the slides and you take it from here.
Madam Chair,
Welcome back, Jesse.
Oh, thank you very much. When we say mandatory and optional, these are mandatory and optional under federal law. So under state law, many of these are required by state law that the legislature has added these as covered services. So when this terminology is just federal terminology, that if we did the absolute bare bones mandatory services, that would be that mandatory services column. The optional services, I think, in 1965, some of these things, or 68, or whenever these different things were deemed optional, they might have seemed optional, but for a lot of medical care, in 2020, you wouldn't necessarily want to run a Medicaid program without prescription drugs, for instance, or clinic services, which could be federally qualified health centers and rural health centers. But there's other clinics in Wyoming that are in shortage areas that aren't federally qualified health centers, rural health centers, which would create an access issue. So when you're looking at this, I think it's important to just think through while they're deemed optional from a federal standpoint, they may not be optional from a normal healthcare coverage standpoint that, most people would expect these things to be covered. For instance, at the bottom of this page, you see tuberculosis related services. I don't think we would suggest you not cover tuberculosis related services. It doesn't happen very often. It's pretty rare in Wyoming. I think we've had one case possibly, or my career here, but it's just not something I would suggest you not cover. And it's into Medicaid for a reason, to basically help prevent outbreaks and things like that. Any questions on this slide before we move on, Madam Chair?
And I can't see all the people because of the way the slideshow is. So if there's anyone there, just call out yourself.
Madam Chairman,
Chairman Scott. I was thinking of you, yes.
Madam Chairman, and let me say at the outset that I find this paper to be extraordinarily useful, and compliment the Health Department for getting it down succinctly. I'm going to ask a bunch of questions. Frankly, I've heard a number of members, including some from this county, saying that we can cut our way all the way out of our financial troubles. And I don't see how they can do that without taking a major whack out of Medicaid. And I want to be able to, I'll ask you some questions about potentially cutting things I wouldn't advocate, but I want to be prepared if somebody tries to cut them. And some of them I might advocate. First question is, am I right in thinking that if we cut out a service that you've listed as mandatory, the consequence for that is that we lose the whole Medicaid program? Is that a correct understanding of the federal law and policy?
Madam Chair, Co-Chair Scott, that would trigger that we wouldn't have a compliant Medicaid program. So if you don't offer the mandatory services, you're really not offering Medicaid under federal law. So you're not then eligible for federal match. So I think you really, we strongly suggest you don't cut anything in the mandatory column.
Yeah, and frankly, otherwise I would have tried it a long time ago, because there's at least some of those things that I think we could do cheaper with just our 50% match than we can with the feds. But you lose things like the nursing home match and the DD match, and we can't afford that. On the optional services column, I agree with you on the prescription drug. I think if they try cutting that, that's cutting your nose off to spite your face, because it'll show up in higher hospitalization rates and all that sort of thing. Could you talk a little about what's in this medical care by licensed practitioners? Is there a lot of money there? What sort of things if somebody tried to cut some of those out, what sort of consequences would we get?
Madam Chair, Co-Chairman Scott, so I think the biggest expense in that category is behavioral health. So you're seeing all of your psychiatrists, psychologists, licensed mental health professionals. So that's, between adults and children, that's a pretty large expense for the whole mental health. And that's paid to a lot of the same providers that you're paying for with the other mental health programs in the Department of Health. So if you're cutting the Medicaid program for those same providers, you're losing the federal match for a program that, there's that. Chiropractic is not a very large expense. I think it's been about $350,000. We could list out these by these types if you'd like, but in this category, I would say behavioral health is likely the largest.
Madam
by
Chairman,
significant margin.
it would be useful if eventually they could get me that list. I don't really need it much before session, but I'm probably going to need it then. The other screening and prevention services, next thing, what is that?
Some of those are tests. That's not going to be a very large category because most of those are going to fall under other categories. So it's not going to be a very large category overall. So generally, when you get to those are screening and prevention that are covered under a normal physician's office visit. And there's just not a lot of that type of service.
Okay.
But we can, we can obviously qualify that.
Does the same apply to this clinic services thing that's the next thing down? What's the difference between that and outpatient hospital?
Madam Chair, that would be, Co-Chairman Scott, that would be a standalone clinic. So it would be a clinic that's not an FQHC or rural health clinic. So there's just clinic services that haven't received those designations, but are, I think, clinics in your communities you'd be familiar with. So those are like physician clinics that are operating under a clinic versus a physician.
Okay.
And Madam Chairman, if I may, to Senator Scott's point, we are more than happy to, over the coming weeks and months, to put together an additional column on a table like this to not only estimate, and it will be a little difficult in some of the categories because they go back to definitions from the 60s and 70s, but we could estimate the spending and utilization there. And also clarify, Senator Scott, like Jesse's doing, what's included in each one of these categories, and provide that to the committee.
I think that would be really helpful.
Madam Chair, one caveat, just to, we always divide these up between children and adults because a lot of services for children, once that service there in the mandatory called early periodic screening, diagnosis, and treatment, under federal law, once you've screened a child for something and determined, made a diagnosis that they have that condition, under federal law, we're required to treat that condition. So for children, we end up covering, even if you removed it from as an optional service, for children, we cover a lot of optional services under that mandatory service. And so it's happened before, and you've reduced services for adults, but we don't actually reduce the same services for children because you really wouldn't be able to realize those savings. So we almost always differentiate this presentation between children and adults. And we just don't spend as much on children anyway. Children make up a vast majority of the program, but they're just not, that's not where the money is. The money's on adults.
No, if we paid for children's shoes now, that would be a different thing, but.
Madam Chairman, if they will provide that list that we're talking about, that'll solve a lot of my questions. I do have a couple of others on that side of things.
Go ahead, Chairman Scott.
Madam Chairman, the home health care services, what are you talking about there? Is that the general funds only program you were talking about earlier, or is that something else?
Jesse.
Madam Chair, Senator Scott, the home health care services would be in that area would be generally medical type home health, where you're recovering from some sort of injury. Home health services for individuals that are nursing facility eligible is a mandatory category, but there are a bunch of home health services provided to developmentally disabled individuals, intellectual disabilities, people recovering from an injury. So those are the same type of home health service you would think about as home health, but they're just optional for other populations that are not nursing facility eligible.
And Madam Chairman, Senator Scott, this is not the general fund only Wyoming Home Services Program. This is just Medicaid.
Okay, that's the question I had. waiver services, 915, et cetera. What are you talking about there?
Madam Chair, Senator Scott, the entire waiver program, so really all of the home and community-based waivers are optional under federal law. Again, I don't think we would recommend you eliminate any of the waivers, but all of them are by definition optional in federal law. But most of those individuals are eligible for an institutional level of care that is, in many cases, exponentially more expensive than the home and community-based options. So, and I think that's an important consideration when you look at these optional services. Some of these optional services are actually less expensive than the mandatory services and were added later as options.
Yeah.
So, you know, if you start cutting the optional services, in some cases, you'll increase the budget because most people, for instance, on the community choices waiver, long-term care waiver, many of those people were going to nursing homes before and are now not going to nursing homes. And nursing homes are 4 times as expensive in a lot of cases as the same amount of time on the community choices waiver. So I think when you look through this, I think that's also something to keep in mind. Similar, I think, you know, when you go through this, if you have specific questions, we could respond to those and clarify what all these are.
Madam Chairman, it sounds like that's in the same category as the prescription drugs. I don't understand the difference between the waiver services on the optional and the home health services for individuals entitled to nursing care that's on the mandatory. What's the difference between those two?
Madam Chair, Senator Scott, the difference there, so home health is a very specific licensure where you actually have a home health licensure. Some of the other things there are, so a lot of what you would think of like help around the home is not necessarily home health when it falls under a waiver. It's actually what we classify as personal care. And so those type of services are, you know, just general, not your once or twice a day visit from a home health nurse, but actually different types of assistance around your home. Those generally fall under personal care. And a lot of the personal care services are actually in Wyoming under waiver. There's not a lot of personal care that's actually provided under the state plan, which is just without waiver.
Madam Chairman, I'm still not clear as to what is included on the mandatory home health services category.
Well, so wouldn't, Jesse, wouldn't that be something like if a person suppose they were in a hospital and they were going to go to a nursing home because they needed to have some sort of a tubing thing changed in their body, or, you know, an actual nursing type thing. I mean, an actual nursing care as opposed to someone who's giving them a bath.
Madam Chair, the home health there, the 4 individuals entitled to nursing home care is a population. So for that population who's met the qualifications to go to a nursing home, even if they're at home, they qualify for home health. Everyone else, all those other groups we talked about, if you're not eligible to go to a nursing home, it's an optional service. But if you've had a medical assessment done and it says this person qualifies to go for a nursing home, that is a mandatory service. So it's really only mandatory for a subset of our population. The rest of the population, home health care, is optional. And so I think I tried to give some examples of that, but that would be somebody recovering from a surgery. That could be somebody with developmental disabilities. Those home health care services are optional under federal law. I don't think that, you know, if people looked at those actual situations, they would think they're optional, but they're optional under federal law.
But so the waiver services that are to keep people out of nursing homes that qualify for nursing homes, you say that those services are mandatory if they qualify for a nursing home and optional if they don't. Is that, am I understanding the distinction there properly?
Madam Chair, Co-Chairman Scott, so there's just an array of services that are additional to home health that someone on the Community Choices waiver would get. So they're getting personal care. They might have a remote monitoring device, those type of things. Those are the additional things. Actual home health has very standard definition. It's related to like recovery, restorative, home health. If it's just maintenance home health, then it starts falling over to the optional side. I mean, this area is honestly very confusing. It might be better for me to write it down or our group to write it down for you.
Okay, because that is, as this chart, Madam Chairman, I think is going to be key in dealing with some of the things that could well come at us during general session, and a written explanation on that one might be quite useful.
That would probably be good. Did you have some more questions, Chairman Scott?
Madam Chairman, no, that, given the promise for some more information, that answers my questions, but I do think we're going to have attempts to cut Medicaid during session that I'm going to need that sort of information to deal with. And maybe I'm overestimating the seriousness of our budget problems, but the projections I've seen sure scare me.
Is there anyone else in the committee who wants to ask a question and I can't see you?
Madam Chairman, Eric.
Representative Barlow.
Thank you, Madam Chairman. So my question is, and I appreciate the information, but I would like the subsequent follow-up to actually be in reference to 424103, which is our authorized services and supplies, because I think that would also be instructive, because that is a legislative position that we have enacted in statute. It says we are going to provide these services, or these services are eligible to be for Medicaid. So, and some of them, I know there'll be some services are and some aren't, but I think understanding that. The second part of my question is whether it's the 424103 list or it's the list that Mr. Springer went through, is there a way to assign dollars to the different optional and mandatory programs or services that are outlined in there, so that we can actually understand those cost savings, get rid of a optional service, and you might probably have a subsequent increase in a mandatory service, so we can understand those interactions, if that makes sense. So thank you, Madam Chairman. Both of the two questions. One, is there a way to do that with 103? And two, can we have some dollar and associations between either that list or both lists? Thank you, Madam.
And Madam Chairman, this is Stefan. If I may, leave it to our good majority floor leader to come up with a better option than I articulated. I think that's a really good way that we'll circle back with the team here and kind of give an addendum to that white paper, because looking at state statute and then doing an estimation of utilization and dollars, as well as kind of a matrix of mandatory and optional, I think that's very doable. So good suggestion. We'll follow up and come up with a way to do that for you all.
And Stefan, I think that, and it was kind of mentioned just now by you, but if we can get a rough number of the number of people who are covered under that, I suppose we might leave it to people to do their own math, but you might just do it for them. And then, what's the per person cost per year or whatever for these things? Because, it's easy enough to say, well, I can't believe we're spending $8 million on X for 100 people. But then if you kind of mesh it over and say, well, those 100 people at, 230, you know what I'm saying, is that it would probably be helpful to know the numbers.
And Chairman Wilson, we'll take a look at that. Just a little bit of preemptive caution for the committee. When we're talking services versus people, when you start adding the people, you get into a lot of mix of, you know, a certain type of group will fit into multiple service array categories. So we'll take a look, but just a little bit of caution that it might not shake out exactly like that, but we'll do our best.
Well, and so you might not necessarily put out, you know, how many people get doctor care or physician service. I mean, that you're right. That would be just lots and lots of people. You don't know how many visits per person or whatever. But I remember, oh, way back, I think this was even the year before I came into the legislature, but just something really basic, like how many people are on the comprehensive waiver, how many people on the support waiver, how many children are in Medicaid, how many family care, you know, just, I mean, probably numbers like that, just is so that we have them in this same document and you don't have to run around looking it up, would probably be good.
Yeah.
Madam Chairman.
Sorry, go ahead.
Chairman Scott.
Madam Chairman, are you asking for those population figures on a snapshot basis or an annual basis? Because those are quite different figures, because you get people that will be on Medicaid for a month or two and then they're off and then they come back on. You get quite a bit of that. So you look at it, total number of individuals served in a year, get a very high percentage of the population, much smaller percentage at any one time. So which one are you asking them for?
I think what I'm trying to do is preemptively provide information so that if other legislators or people on appropriations or something say to themselves, well, we're spending $8 million on this and there's only 6 people, or, you know, I mean, what are people likely to want to do their own math on? People typically want to say, okay, we spend this much in a year and how many people did we spend that for? So I think as long as the department can say what it is, but what people are most likely to do is, I mean, if we had, let's just suppose you spent $1,000 in a year and one person was on for 6 months and another person was on for 6 months, you're basically spending $1,000 for one person for a, you know, 1 year person. Does that make sense? And I think that's, and I don't know, Chairman Scott, you may know more what the thinking of some of the folks will be, but it seems to me that that is the likeliest math project that someone is going to set themselves to.
And
Madam Chairman, it is important to understand whether you're looking at, maybe you gave one person's worth of services for a year. Is it one person, different person each month? So you have 12 people involved, or is it one person for the whole year? And it'll depend on the nature of the service. A lot of some of your long-term things, a nursing home care, something like that, it's one person for that whole time. And a lot of other things, temporary medical things, they may be very expensive, but it may be a number of people during the course of the year on the same thing.
Although most people who are enrolled are probably on for a whole year. I mean, I know they come on and off, but like a child is going to be on probably for 18 years, or, you know, maybe not, their parents might get a job, but you know, I'm not sure I'm going to necessarily set that formula to you, Stefan, you and your folks. If you just look and think, what a person who doesn't know much about this, and they say, here's your budget, here's the number of people, what collection of variables gives a person trying to do their own math the most accurate picture of what they're looking at. I mean, I think I might almost have to leave that to you. And as long as you can then say, this is what it is, that's probably the best way rather for me to say how to do it. You just think through how someone's likely to use it and what is the most accurate way then for people to then compare. Because if they say, well, it costs, you know, 4 times as much to do this as much as that. You just want to make sure that they're doing it all on the same denominator. That, I guess that's what I'm getting at.
And Madam Chairman, challenge understood and accepted. So
Okay.
we'll put something together that I think hopefully distills that information. But again, we just kind of wrap up here with referencing the white paper that you all have that is a little bit, as Chairman Scott mentioned, more detailed. We'll follow up with some of those estimates on funding, as well as trying to tie it to the state statute. I think that's a good idea, and try to have that prepped for you by the next meeting. So happy to stand for additional questions, and especially while we have our Medicaid expert, Mr. Springer here.
Very good. Any more questions? I can see all of you now, I believe. So I see no blue hands. Chairman Scott. You're muted if you're trying to talk.
I have a question on page 6 of the paper. Is that appropriate at this time?
Sure, go ahead.
The CHIP program, what would happen? Would we trigger losses in other programs if that program got flat abolished? And how much are we spending on that program a year?
Jesse?
Well, one of the slides had the maintenance of effort. So that both Medicaid children and CHIP are subject to a maintenance of effort that was in one of the extensions, previous legislative extensions by Congress until 2027. Generally, I think if you violate those, you can put your awards at risk. So I'm not aware that any states ever violated a maintenance of eligibility. So I'm not sure what would happen, to be really honest, what kind of penalties we could be subject to. Generally, if you do violate them, they just take the money. So Medicaid is on a reimbursement basis. So they just don't reimburse us. So we spend our money and they don't reimburse us. So it's not really that they give the money to us in advance, like a grant, and take it back. We spend the money, they reimburse us. So if we have violated any of the federal laws, they just wouldn't reimburse us for the quarter.
And Madam Chairman, Senator Scott, I think to your question, if we abolished CHIP, would it affect other service areas in Medicaid? And I think the answer to that is no. It's kind of a separate authorization and a separate match that's in federal law. So as an optional program, I think, again, we've been asked this question a lot by the Appropriations Committee over the years. What would happen if you abolished CHIP? And really, I believe it's about $8 million in change general fund and about I might need to check those numbers, but 13 or 14 million dollars in federal funds. But we can certainly provide that information. Essentially, the answer is that the coverage would not be there for about 3,500 kids, and that federal match would go away.
Question, is that 8 million a biennial or an annual figure?
Madam Chairman, Senator Scott, Jesse, you can correct me if I'm wrong. I believe that's a biennial figure, but we'll get you the details for the current biennium.
Madam Chair, Senator Scott, I think a lot of this is that, the numbers have been reduced significantly. So that was one of the areas that actually took a pretty significant budget reduction and the step 2 reductions. So I think we need to get back to you with the new lower number. We're still waiting for some of that to be loaded into our budgets, but it should be it's about 30% lower than it was, and so we'll see how it actually turns out. It should be a bit lower than it's at a different lower expenditure level with some of the changes that have been made recently.
Just in there, I didn't notice that one on the page, or if I did, I read it earlier. What's the changes in the CHIP program? I see here. Okay, I knew about the change to administration. What's the other change is in the CHIP program in the reductions?
Madam Chairman, I don't believe there's any. It really is, I think, a lower administrative cost on CHIP by taking it in-house. And I think moving forward, we'll look at what the reimbursement rates and what that would mean to equalize those with traditional Medicaid for the lower income children. Those two changes would be the main reasons for the budget reduction there.
Okay. All right. Any final questions for, I think this is pretty much the end here. I'm not forgetting public health, but are there, or sorry, public comment. Are there any more questions regarding the budget cuts or the federal match and maintenance of Everett? I see none.
Thank you, Madam Chairman.
Okay, thanks very much. Although I guess you'll be right back. At least somebody will. Okay, Elizabeth, do we have any, I guess we can, okay. Do we have any public comment on the Department of Health's presentations on the budget reductions or the federal match?
Ma'am, we do have one individual for public comments, Mr. Ramsey Scott, and he had signed up for all agency report budgets. So I don't know if he has one specific to health or to everybody. So we will.
Oh, yeah, you know, and I don't think I took public comment on corrections or family services specifically. So if there was anyone that had them on any of those, obviously they can come in.
Ma'am, I believe Mr. Ramsey Scott is our only individual at the moment for public comment on this entire topic. So.
All righty, send him in. Mr. Scott, welcome back.
I just, have to take every chance I can to bug y'all.
That's right. You be
Ramsey
careful, we'll
Scott.
put you to work.
Ramsey Scott, Public Policy Manager with the Alzheimer's Association Wyoming chapter. I just want to take a quick second as we're talking about these budget cuts to just highlight some of the drastic impacts it's going to have on the 10,000 people living with Alzheimer's disease and their 28,000 unpaid caregivers. And before I even do that, I just want to say that Director Ceballos, Stefan, the whole staff over there was put in an almost impossible task, trying to make drastic cuts less painful. And I think they did as good of a job as they can. But as you and the rest of the legislature look at what the 20% more cuts that might have to be made, that just to talk about, just to pull out one thing alone, the home-based care services, we know it's not the only home-based care services program in the state. There's Stefan was talking about, but that does affect almost 2,000 people. And we can expect the budget office was the Department of Health estimated that almost 120 people or so direct care staff are going to be laid off with that as well. Those are people that aren't going to be providing care. They're also not going to be contributing to the economy with at their local stores. And so this is going to be affecting everyone. And so I just want to kind of point out that I know that there is the narrative out there that these cuts are just part of dead weight. Wyoming has done an amazing job to create a very efficient government, and there's nothing left to cut. And that every dollar that is being taken out of these systems is going to have a drastic impact. And so just want to take any chance I can in the public to make sure people realize that these cuts have real life impacts, and that when the legislature meets in next year and they talk about, well, we can just trim and trim and trim, that's just real people's lives they're affecting. And so we know that you've done a lot of great work and the Department of Health's done a lot of great work, and we take every opportunity we can to make sure people realize these cuts have a drastic impact on a lot of Wyomingites. So I won't take up any more of the time because it's a late day. So I'll stand for any questions if I'll have any.
Questions for Mr. Scott? I don't see anything. I think we understood you all too well, frankly.
I think y'all do as well. Preaching to the choir may be a little bit there. Thank you so much, Chairwoman Wilson, and y'all have a great afternoon.
Thanks, Mr. Scott. Okay, no more there, huh? Well, let's see. It says lunch. No, we had that already. All right, last item on the agenda, we're actually doing pretty well here, is what is titled COVID-19 Response, Ways the State Can Be Better Prepared for Future Pandemics and Possible Approaches. I just want to say a couple things before we get into this, and I believe it will be mostly Department of Health. I understand that they've worked closely with Homeland Security. So back in, when we put together the interim topics, Co-Chairman Scott and I thought at the time that maybe by the August meeting, the COVID would have come and peaked and gone, and we could hear from the agencies what worked, what didn't work, what might we have to do for the future. Because realistically, if you're at all involved in public health or have just even lived for a couple of decades, this is not the first epidemic of any kind that we've had in Wyoming or in this country, and it will surely not be the last. You know, you think through even just AIDS, which of course had Ebola, Zika, which was not here, but in South, and there are a lot of different methods of transmission. You know, whether it's transmitted by various kind of blood-based situations or birds, mosquitoes, you know, viruses floating through the air, whatever it is. It's hard to prepare for the future and not get yourself tied to fighting the last war, you know, because things may change. And so what we really wanted to do was evaluate how the state agencies and also community providers like hospitals and nursing homes, whatever, how they had been able to respond to this and what changes or future preparation there might be in terms of stockpiles and that kind of thing. So we have sort of a short list there of some things that came to our mind, licensure type things, whether they're enabled to do certain things or trade off stock licensing requirements, the data reporting, group purchasing, whatever it might be. I do want to put a caution here that certainly that we have heard some people's discussion about the specific topic of state health orders. I just want to say that Management Council has assigned that topic to the Corporations Committee. I know they are evaluating that, whether they have some bills or a task force or whatever. And so I do not want to spend any time on discussing the topic of the actual authority of the state health officer, because that will really duplicate the Corporations Committee's work and we could go on about it for weeks. So what I want to hear from the witnesses and people calling in from the public is specifics as far as on the ground public health responses and planning for the future. That is what we are going to talk about. So I think we have probably Department of Health is going to lead off, and then we'll see who else we have.
Thank you, Madam Chairman. Once again, Stefan Johansson, Deputy Director for the Health Department. I believe LSO may be admitting Stephanie Pyle, our Public Health Division Senior Administrator, as well as Dr. Alexia Harris, our State Health Officer, to be available to answer any questions or correct any misstatements on my end. But just really quickly, and Madam Chairman, we don't have to go into great detail here, but I did want to point out to the committee just on a few updates on the data. The past several weeks have changed significantly where Wyoming is positioned in terms of the virus, in terms of the pandemic. So I thought it would be useful to point some of those things out. And then just a brief discussion. Again, I'll hit some of the highlights, let Stephanie or Dr. Harris add any thoughts or observations they have per your request, Madam Chairman, on lessons learned so far, what has worked, as well as some ongoing challenges that we face. Like you, maybe it was a naive optimism on my part, but I also thought maybe we would be discussing at Joint Labor some of our after action report at this time of the year, if not earlier. But here we are. We still see significant transmission of the virus, and I think you'll see that in some of the data here. So as of last week on Friday, we did, we have seen on a 14-day average, what you see on this chart is the daily number of cases. And it's a little bit noisy in a place like Wyoming to just look at the raw numbers, but you can certainly see all of those numbers on our website. But when you look at a daily average, that really gives you a sense of how it's progressing in terms of the overall number of positive cases that are identified. So you can see that upward growth really since the beginning of September, and certainly going into the first part of this month, just in our number of lab confirmed cases of COVID-19. Did want to point out to the committee that if you look at this chart going back to really April and the beginning of May, you can see the significant uptick in the number, in the volume of laboratory testing for COVID-19 that has happened statewide. And again, I'll just point out all of these charts are available at health.wyo.gov on our website. And you can see both in terms of the Wyoming Public Health Lab, which is shown in green as WPHL, as well as our non-Wyoming Public Health Lab sources. So that's everything from a hospital laboratory, a private laboratory, reference laboratory, which would include any of the entities we have contracted with to supplement our COVID-19 testing strategies. You can really see, especially getting into July and then certainly into August and September, a significant uptick in the volume of testing that's not only being performed, but that's available. And so that's, has been an overt strategy from the department. Certainly not perfect. Everybody around the country has struggled with supply issues, logistics issues to get these tests performed, but we're trying to increase that as much as we can as one of our strategies to manage the effects of this pandemic. I will mention, Madam Chairman, that if you look, at kind of where you see October 1st on this chart, it looks like we've dramatically fallen off. There is a little bit of a lag time of when we get the results. So that is not accurate when you look at the beginning of October. You'll see those pick up as we get the reports in from the various laboratories. Finally, Madam Chairman, on the data update side, as you know, we track our COVID-19 hospitalizations as reported by Wyoming hospitals. This was again as of Friday last week. That has increased. We've seen the highest number of COVID-19 hospitalizations really in the past week or two since the pandemic began in March. That has increased again as of Sunday and Monday this week, where we have seen just a number of increased COVID-19 admissions reported by our Wyoming hospitals. We are working on and hope that this doesn't develop into healthcare system capacity issues. As Dr. Harris mentioned yesterday at the governor's press conference, a number of our hospitals are quite small and have a limited number of ICU beds or any intensive care type of beds. And so the whole reason, when we started these efforts back in March, one of our biggest concerns is what does this virus mean for the healthcare system capacity in Wyoming, not just in managing or treating COVID-19, but all of the other needs that our residents have when accessing hospital care. So this is certainly a concerning trend. I think I would echo the governor's comments yesterday that our number of cases and our number of hospitalizations have been of concern over the past 2-week period or so, and we'll certainly let Dr. Harris comment on that when we wrap up here. But I did want to mention, Madam Chairman, that it's a project or an initiative that hasn't gotten much attention with this committee, just because during our last meeting we were kind of in the stages of rolling it out. We do have an active and alive wastewater testing strategy to supplement our diagnostic COVID-19 efforts, and a number of cities, of municipalities or localities have joined us, and we are getting more joining every week to where they collect samples of wastewater in their community from their wastewater plants. And we've actually developed the capacity at our public health lab to test that on a very sensitive level for COVID-19, and just give another data point to decision makers, both at the state level with the Department of Health and the governor, as well as we roll this out, local decision makers and members of the public to be able to see what the COVID-19 prevalence is in the wastewater in their community, and what that might mean for the virus. But it's really about giving additional data to decision makers. And I'll just mention very briefly, Madam Chairman, that if you visit covidwastewatermonitor.wyo.gov, again, covidwastewatermonitor.wyo.gov, you can see kind of what the Department of Health, really the director's office, our epidemiologists, and our public health lab have partnered to really have a statewide strategy for this type of wastewater testing. And there's, again, very, very good and interesting data here. You can see all of the different communities that we have participating in this project, what their prevalence rate is at different confidence intervals, as well as clicking on them and seeing kind of how that models. We our data science experts, who you all probably know well, model this prevalence rate out to, again, not to sound like a broken record, but give additional data and decision-making power to our various policymakers and decision makers as we manage this virus. The other thing that I would mention is we're working with facilities, including the dorms at the University of Wyoming, the state health facilities, DFS, boys school and girls school, really on a facility level to monitor that wastewater, to see if we can develop maybe more of a tripwire kind of theory, where if we start to see a prevalence increase, that maybe that would cause us to deploy resources like more intensive diagnostic testing, more widespread testing at an earlier stage. So again, this is really related to, and I'm sorry, I'll show the facility specific monitoring down here. So you can see with DFS and with the University of Wyoming, again, a similar type graph, but specific to those facilities. And we'll be bringing on the health facilities hopefully soon. So again, that's really intended to, on a more targeted basis, maybe have some additional early identification of concern. Not necessarily that we would, in a vacuum, act on this data for a certain provision of a public health order, but it's part of that ecosystem or universe of information that has been so difficult with a new, a novel virus like this, that in the early stages, very little was known about its transmission rate, its true prevalence, its attack rate, et cetera. And obviously we've learned a lot since January, February, and March. But this is just another tool in the toolbox to help us there. So, Madam Chairman, if I may, just a few brief, per the committee's request, since we're not in an after action report status yet, but a few initial lessons learned. And I want to talk about a number of areas of what has, in our judgment, our opinion, worked so far. I will caveat this, that so many people across the department, and I won't belabor the point, but so many people across our department have just worked tireless hours since the end of the legislative session earlier this year, and deserve a lot of credit, a lot of kudos, more people than I think you would care for me to name now. But the department has really been kind of an all hands on deck mode for the past really since March when it comes to COVID-19. And that's led to a really good process for decision making among department leadership. So I know there's been some comments and some issues raised over the past several months that decisions are being made in a vacuum. And Madam Chairman, to your point, folks looking at not only department authority, but state health officer authority, and certainly well within their purview to do that. And we've been at the table for those discussions and look forward to continue to be at that table. But I did want to mention that whether it's the public health orders, whether it's strategies for testing, resources that we deploy, CARES Act dollars that we spend, we have a very good process in our department at the leadership level, both here in the director's office and with our divisions, for making decisions. So no public health order, changes to those public health orders goes out the door before numerous people, including our director, have put eyes on it, made edits. We've had discussions about what the changes are, what data is driving those decisions, et cetera. Secondly, the collaboration among the executive branch has been really good, and nobody knew what we were getting into or being thrown into back in February and March. But I think when it comes to various rules and policy, for example, our ability to be flexible with certain purchasing regulations when it comes to CARES Act dollars, to be able to purchase things quickly, not irresponsibly, but quickly, so that we don't have to go through a 6-month RFP or competitive procurement process because of the emergent situation. That collaboration with various branches of government, including A&I, the governor's office, our other sister executive branch agencies like DFS, Workforce Services, has been very seamless and a benefit to Wyoming that we're a small state, and I think we all know each other probably too well at this point. The statutes that we have, Madam Chairman, for data collection, and not just for, in Title 35, the section of Title 35 that really enumerates the department's health authorities, but also just our ability to get reporting, legal ability to get reporting from laboratories, from hospitals, things of that nature have really facilitated our ability to collect data and make better decisions. Dealing with me and Franz for so many years, data is never perfect. It always has its limits. When I showed the hospitalization dashboard, I always caveated that that's as reported by hospitals. There's human error in all data reporting of this nature, but that has been very successful. Next, Madam Chairman, our ability to procure and distribute personal protective equipment. We have a team at the Department of Health, as well as our friends at Homeland Security. That's something that, again, with the supply limitations that we saw across the entire country, we've, in my assessment, have done a very good job getting PPE out the door to our county emergency managers, being able to take care of our providers when they ran into shortages. And as we've continued into the late summer and now early fall months, we've been able to work directly with vendors, large vendors like Amazon, where we have a personal contact to procure this kind of stuff, looking forward of what we might need between the time when we have a vaccine or a treatment that starts to reduce our prevalence with this virus. That's really a big part of our strategy for this pandemic management. And a couple of final things, Madam Chairman, before I hand it over to Stephanie or Dr. Harris on what has worked, if they have anything to add. The stakeholder engagement and feedback that we've gotten throughout the stage of this process, it's always been interesting. I think it's been very positive. A lot of it constructively critical, I'll put it that way. But when we were first developing public health orders and in fact had them in place, there was very good collaboration, for example, between the Department of Health and the Business Council, who facilitated a number of conversations with local businesses that frankly were not happy with the health orders. And we totally understand the economic impact that some of those orders had and potentially continue to have. But as we looked at getting to a new stage of the virus and what we might relax in our orders, again, we didn't just do that from a naive health bureaucrat or physician perspective. We reached out to restaurant organizations and Business Council facilitated meetings where we could get their input on if we were to relax, for example, the orders on restaurants. What would make sense for you all operationally? Is it a capacity limitation or is it a distancing limitation? So that, I don't manage a restaurant, thank God for everybody who goes to restaurants, but that's something that, again, across business organizations, Department of Education and school districts, child care centers, et cetera, we did try as best we could to seek that feedback and have their input inform our decisions on public health orders. We also, as you all know, we had this was a bit unique for Wyoming. I think other states had variations of this, but I don't think it was the norm. We did have a significant exception request and variance process at the local and county level for all of our public health orders that have been in place. And again, it won't please everybody, but we did want to make sure that it was clear we knew the virus wasn't impacting every community equally. We had and continue to have clusters and increases in certain places and not in others. So for local businesses, for example, who were subject to a public health order and maybe closed to a certain degree or had to meet certain restrictions, there was a process by which they could request an exception through their county health office and then ultimately approved by our department to say, hey, I can meet the intent of this public health order, but I would do it in this way. I think, I can maintain all of the protections, I can maintain the infection control, the distancing, but that was really the exception request process on a really, a narrow and targeted basis. And then each county had the opportunity and to request a variance, whether it was more restrictive, which we did have a request for more restrictive orders or less restrictive orders based on where they were with the virus at that time. So that was somewhat unique to Wyoming. And again, as much work as it created both for local communities, county health offices, and our office, I think it was uniquely successful in our ability to tailor this management to our local communities and counties. And then finally, I'd be remiss, Madam Chairman, if I didn't mention, we are just so fortunate in this state and haven't said it enough with the expertise that we have at our public health laboratory. I've learned a great deal about our public health lab since the beginning of this year. And it's impressive what they're able to do. They're one of a few labs across the country that have the level of advancement that they do. We've been able to, manufacture and make our own supplies in many cases, help out other states with supplies at their laboratories that they were missing because we're able to, because we have that expertise and have been able to be quite successful at our public health lab. We just have a wonderful staff who really knows the work that they do. And as we continue to expand and as we continue to ask them to do more, just wanted to point out that that's been a huge part of our ability to respond to this pandemic. But I did want to, before we move on to the final slide of what has been challenging or ongoing challenges that we have, if Dr. Harris or Stephanie Pyle have anything to add, please, Dr. Harris or Stephanie, Madam Chairman, if that's okay with you.
That's fine.
Good afternoon, committee members. This is
Hello,
Stephanie. Hi there. This is Stephanie Pyle, the Senior Administrator of the Public Health Division. In the room with me today are Dr. Alexia Harris and Dirk Dykestal. And we did have an opportunity to spend some time brainstorming. And truly it's all we think about every day is our response. But we did have an opportunity to sit down and really think through, what's worked and what hasn't worked throughout this pandemic. And, to say it's been a challenging year is obviously an understatement. We have learned a lot. We've made adjustments as we've gone, and Stefan's words captured it well. We've had an all hands on deck approach, and we've incurred many challenges. Some we anticipated, some we did not. But I'd like to just mention to the committee, the Public Health Division and the individuals involved in the response include our epidemiologists, our lab staff, our public health nursing offices, the local health departments, and our health readiness and response team. Early on, we managed this response with our own staff internally, and quickly we realized that we needed additional staff, so we did have the ability to expand. We also collaborated with state agencies right from the very beginning. I remember the early days in March, being in our State Health Operations Center with Homeland Security, making late night calls with our federal partners to try to help people, with their immediate needs that were coming up long before, what felt like long before the pandemic really hit in Wyoming to the extent that we've seen. We have just been able to pivot and act quickly and change what we're doing, what feels like at a moment's notice, to do things like expanding testing, obtain PPE, get that out to communities where the needs are, to improve and increase our contact tracing efforts. And we've been doing this since March, but now we're seeing very concerning numbers, which Dr. Harris will talk about in a moment. But I just want to reiterate to the committee, you've got state workers here and across this state who are working 7 days a week on this pandemic. We haven't done everything perfectly, but we have tried our best. And, we just continue to do that. And the work is far from over. We'll continue to work with our, partners and entities around the state, including long-term care facilities, school districts, the university, community colleges, business organizations. We know this is not over, and we're here for the challenge, and we appreciate any support you can offer. And with that, I'll turn it over to Dr. Harris.
Thank you, Stephanie. Madam Chairman,
Dr. Harris.
Thank you, Madam Chairman. Allie Harris, State Health Officer, Wyoming Department of Health. Really just a couple of things to add, going back to Stefan's point about the increased hospitalizations. Just do want to point out how concerning that is. The preventing our hospitals being overwhelmed with COVID-19 patients has been one of our primary goals throughout this pandemic. Of the 6 metrics that we track and report publicly on during each press conference, 3 of them are related to hospital capacity. We know that we are not alone in our region in terms of states seeing a large increase in cases. And of course, knowing that and hearing that hospital capacity is an issue in at least one of our neighboring states in Montana, brings up that level of concern even higher. And of course, we've seen earlier in the pandemic with other states that had kind of that exponential growth during the summer, hospital capacity being threatened in those areas as well. So it certainly is a signal. We knew that we were going to continue to see transmission until we had a definitive preventative measure like a vaccine. But with hospitalizations increasing, certainly hearing from hospitals about the pressure that they're feeling, this is a point to note in this pandemic and a signal that we do need to turn these trends around. And as I'll also reiterate what Stefan said about our public health laboratory, we certainly had to increase our capacity to perform the type of testing that we have, but we had the expertise in-house to be able to do that without depending on any external entities. That was critical. And I would say the same for our epidemiologic team as well. We had the expertise we needed to take the control measures that we needed to take through contact tracing. And so while we've added people, and now of course, as the governor announced yesterday, have asked the National Guard to help temporarily with that because of the surge that we're seeing, we had the expertise to know how to do that already in-house. So I will stop there, Madam Chairman.
Okay, Stefan, do you want to take questions on the positives before you hit the negatives, or just kind of glob it in all together?
Madam Chairman, I'll use your word and glob it all together. If you'll just indulge me for another minute. In terms of some ongoing challenges, I want to be clear and have, really gotten to know our team really well over the past 6-7 months. And so, as Stephanie mentioned, these are things that we're constantly discussing of honestly what isn't working now. After we doted on the department for the successes, this has been a challenging process, and we think about these things and try to manage these things often. Communication it just keeps coming up as a huge challenge with something as complex and unknown, and so many actors that are influenced by how we're managing this pandemic, that it's been difficult to communicate effectively all of the nuance and detail to a wide audience. Not only the contents of the public health orders, which are often changing on a 2-week basis, which is difficult to effectively communicate, even though we do our press releases, we do our press conferences, or the governor and Dr. Harris do. We do our media blasts, et cetera. It's just difficult with something as novel and unknown as this has been to really communicate effectively on those contents. In addition, like I mentioned before, that there were exception and variance, exception request and variance processes that certainly we communicated that down through our chain to our county partners. But I think for the general public, that awareness, if we don't just annoy you all with TV ads all the time at night, or blast the internet of how we're doing this, and it's really has been difficult to capture all of that detail and nuance, especially as things have evolved and changed. Our flexibility to increase human capital, like I mentioned, one example was at our lab, and as Dr. Harris just mentioned, we've increased temp positions and other positions at our epidemiology unit. But one thing to point out is while that's been good, and we've had slots available with our temp positions across the departments, budgeted positions, they may not always be available. So there's a bit of uncertainty, especially going forward, of, we've thrown a lot of people and transitioned a lot of work duties, both in the pandemic response and at our facilities. A lot of things have changed with our human capital, and that might not always be, as easy to manage. So we certainly wanted to point that out. One thing that we had discussed, and this is just a very, very initial and probably unsophisticated idea, but with a pandemic like this that was just so, different than anything that we have all experienced to date, our personal protective equipment, or PPE acquisition and distribution, was very good, as I mentioned. But we may need some future abilities, depending on how long this pandemic continues, or if others hit, to be able to collect cost on that acquisition. The reason I bring that up is our kind of stockpile of PPE in our preparedness program was historically intended to be distributed to what we call public health first responders. But it became clear with this pandemic and the supply chain issues that were being faced nationally that we needed to start to get this out to county emergency managers to be able to distribute directly to healthcare facilities because of the challenge. And I won't suggest that there's an overabundance of moral hazard there, but I think that the state becoming a PPE or healthcare equipment supplier for a vast, private sector enterprise like hospitals or clinics or physician offices would be kind of a fool's errand. So like I said, it's been good so far. I don't know if there's an immediate need, but in the event that, we did have a significant supply shortage in Wyoming, it wouldn't, and the state had the ability with its purchasing power, with its vendors, or with its associations with other states to get, larger distributions or larger orders of PPE. In the future, the ability to collect that revenue from providers who would want to order from us because their own supply chains are disrupted may be something, Madam Chairman, to pursue in an after action cycle once we're hopefully done with this thing as a potential statutory discussion. And again, like I said, it's not a request from the department right now, just something that has come up in discussions. And finally, again, you'll know that I was going to mention this, but staffing and capacity in a 500-year flood like COVID-19, it's been tough, and offices have been stretched. I think everyone in my assessment across our department has risen to the occasion, including folks in Stephanie and Dr. Harris units, my own units here. Like we said, it's been all hands on deck. But our public health nursing staff, they've had to prioritize this, obviously, and there's just a balance between the public health work that needs to go on versus, a strict prioritization of COVID-19. And obviously, that's a tough balance to strike. But the public health nursing staff has certainly been stretched. That holds true for our epidemiology, our lab staff, and our preparedness and response staff. This is, again, what we always say that we prepare for, and I'm glad that we have, and that we've again risen to the occasion to be able to manage in the way that that we have for the past 6 months or so. But the staffing has been stretched. And again, Madam Chairman, that's not a formal request to the committee or to the legislature at this time, but just a note that throughout the process, it has been operationally a management challenge to, I think in terms of money and people, maybe too much sometimes, and where do you move the money and where do you move the people? And that has been tough as we've looked to really need to increase capacity in certain areas of the department, but knowing that we don't always have it ready and available. So no judgment call there, no solution being suggested, just something that has maybe fit in the, not necessarily something that hasn't worked, but that has been an ongoing challenge. Madam Chairman, I'll see if Dr. Harris or Stephanie would like to add anything to this, but then we're happy to stand for any questions.
Okay.
Madam Chairman, we do not have anything to add. Thank you.
Okay, great. Well, let's see if there are any questions. And remember, we're not going to attempt to amend the state health order procedure at this time. We're going to let corporations carry on with their functionality there, but I'm sure we have plenty of other questions and thoughts. Senator Schuler.
Thank you, Madam Chair. And this question can be for either Stefan or Dr. Harris. Actually, first of all, I would just like to say to Stefan, over here in Western Wyoming, I can't speak for Representative Roscoe and Representative Yin, but myself, I would have loved to have heard updates from the Department of Health in Wyoming rather than listen to all the TV blasts about the Utah governors and the Utah congressmen, but that's aside from here. So yeah, we would take your blast anytime. My question really is concerns the labs. Just kind of wondering now if you feel like your lab staff is adequately, are you staffed adequately now? I know you said you were stretched fairly thin, and just wondering if you feel like that you are where you need to be, or so that we can get results as timely as possible, or do you feel like that's an area that we still need to take a look at closely? Thank you very much.
Madam Chairman, Senator Schuler, I'll answer briefly, but since Dr. Harris directly oversees the lab, I'll certainly ask for her thoughts. I would say in general, yes, but it's an evolving situation. So for example, we're in the process of, again, transitioning a full-time equivalent position over to the lab because of a project that we're scaling up for saliva-based testing, assuming that we won't have wide distribution of a vaccine, until sometime in mid or late even 2021. Hopefully that changes. So we're constantly looking at, do we need to increase our temp slots? Because quite frankly, the workflow at the lab, there's a lot of grunt work that needs to happen when it comes to opening packages, repackaging things. That does involve a lot of human capital, and we've been fortunate to have A&I work with us on increasing our temp position slots. We've had students from the University of Wyoming help us out. We've had the Guard help us out at times, so that has worked well. But I'll certainly let Dr. Harris speak, especially in the current state, how she's feeling about her staffing capacity at the Public Health Lab.
Dr. Harris.
Thank you, Madam Chairman and Senator Schuler. Yeah, I would agree with Stefan. We have had the temporary staff positions available as we've needed them to ramp up capacity. At any given time, we've had between 20 and 30 temporary staff in the laboratory. We've been able also to use the expertise of our chemical testing laboratory that has essentially become somewhat of a viral transport media manufacturing laboratory at this point. We're sending out thousands of sample collection kits every week and manufacturing our own media. Like with any sort of staffing problems, that it all depends on demand and volume. And so while certainly we are in a good place right now in terms of the volumes we're seeing, I would be concerned if we start seeing substantial increases in testing demand and testing volumes, which we certainly could with the increase in cases. And as Stefan mentioned, certainly bringing on any new additional projects would require increased staff as well, all of which we've been able to find within the department to this point.
Thank you.
Okay, Representative Hallinan.
Thank you, Madam Chairman. I have a question for Dr. Harris. What evidence is there that contact tracing and quarantining of possible contacts has been helpful in controlling this epidemic?
Dr. Harris.
Madam Chairman, thank you, Representative Hallinan. As I'm sure most of you are familiar with, contact tracing is one of the really standard tools that we have as public health officials to slow down the transmission of infectious diseases when we don't have tools that we would prefer to use, such as vaccines or prophylactic treatments. We certainly have seen many cases, and I don't have the number in front of me, but could get that for you, of individuals that we have placed into quarantine because they've had close contacts with individuals with COVID-19 who then go on to develop COVID-19. And because they were in quarantine, did not expose anybody else to COVID-19. So contact tracing is one of our essential tools. Of course, testing is another one. Tools that are essential and that we will continue to use until we have tools like vaccines or prophylactic medications, when we can use those as well.
Okay. Further questions?
Yeah, thank you, Madam Chairman. My question is, when the virus is this widespread, that's what I mean. I don't understand why the contact tracing is going to be helpful at this time. So would you answer that question also?
Dr. Harris.
Thank you, Madam Chairman and Representative Hallinan. I think because it is widespread is why contact tracing is so important. We certainly use and recommend the other measures that we've asked people to take, including distancing, mask use. But we know that, nothing is perfect, and staying away from others is the best way to prevent transmission of COVID-19. We have 570 or so thousand people in the state right now, over 1,000 active cases. That is still at a level where if we effectively contact trace, isolate, and quarantine, that we can slow transmission further.
Senator Scott.
Madam Chairman, two questions. First, it's probably for Dr. Harris. I've heard about these, and you had it on these slides about the variances and exceptions to the health orders and other restrictions, both on a countywide and I think on an activity or a business level, but I don't have any sense of the volume that have actually been requested and given. Can you give us any sense of, are we talking just a handful? Are we talking hundreds or thousands, or what's the volume of activity at that level? How significant is it?
Dr. Harris.
Thank you, Madam Chairman. Thank you, Mr. Co-Chairman. I don't have a specific number, but I would say in the hundreds is where I would guess. There are certainly multiple exceptions that we're reviewing and approving every week.
Did you have another question, Chairman Scott?
Yes, Madam Chairman. As I get asked to explain this to people, I'll give you the short answer I've been giving, and my question is, have I got it right, or am I missing something and got it wrong? It seemed to me that in the sequence of things, the first thing that happened was the governor made decision that unlike many states, we would not have a general lockdown. And then almost immediately, you proceeded to shut down a number of or restrict a number of activities based on the risk of transmission through those activities. And then we went to a process through the variances and whatnot of trying to figure out how to ease those restrictions and make exceptions to them by figuring out a way we could do the function could be done safely. Is that an accurate description of the general flow of the response, or am I off on something there?
Dr. Harris.
Madam Chairman, Co-Chairman Scott, I think in general, yes. In March, on March 16th, the President and the White House did come up with guidelines. It was initially 15 days to slow the spread, and then became 30 days to slow the spread, in which they made a number of recommendations to states, including limiting places essentially where people come to gather, public places where people come to gather, knowing that those were the highest risks for transmission. So included places like restaurants, for example, included limiting the sizes of gatherings, etc. As you noted, the state did not implement a stay-at-home order or close, or try to define or close non-essential businesses. We really did try to focus on the places that were most likely to result in significant transmission. So those public places where people came to gather. As we saw that, those efforts were effective, as we again learned more about the virus, had better testing capabilities, contact tracing capabilities, more options in terms of patient care. Yes, began to look at how we could lessen those restrictions in ways that still protected public health. Arrived at the point where we are now, where essentially, and in fact, everything is open. There is nothing that is closed by the orders. But what we're asking people to do is take those measures that we know are effective at preventing transmission in those high risk settings. So distancing, mask use, staying home when people are sick.
More questions for Stefan or the rest of the crew? Senator Bouchard.
Thank you, Madam Chair. I'm holding a picture up here, and this is my daughter back in September of 2007. And we had her in the hospital here in Cheyenne. And our doctor came and said, we got to get her out of there because it wasn't going well. They actually diagnosed in an emergency room that we overdosed her on Tylenol. And what happened when we got to Children's Hospital, and we took an ambulance ride about 3 a.m. and got down there. She had a pneumonia, some type of pneumonia. We didn't know it was viral, what it was. But when we got down there, after a few hours, they tested her, and they actually came to us and said that there was something reptilian. And we said, we don't have any reptiles at our house. And basically what happened was they couldn't identify what had caused the problem. But what I will tell you, what's very interesting, within a few hours, is they said, we're going to give her something that's not conventional medicine to treat what's going on with her. They said she had a storm in her body, and she was being attacked by her own immune system. And they actually said that they were going to give her something that was basically to treat malaria. And so, this is like a teaching hospital down there, Children's Hospital, and you could actually go out in the hallway and you could ask questions. And I actually wrote things down and went and did internet searches, and I just followed it all the way through, got down to the deepest dig I could find. And then I would go back and ask more questions. The reason they knew to give hydroxychloroquine is because in 2003, they knew that people that were taking it in China during the SARS event bypassed the horror that the rest of the people had. So my question comes back to, and look, I've talked to doctors, I've talked to pharmacists. Everybody seems to well, not everybody, let me rephrase that. There's a lot of people I've talked to that do agree that hydroxychloroquine is a treatment. So that way, because what happens is that cytokine storm is what is damaging people when they go too far. So my question really is right now is, what are we doing in that aspect? What is the government doing with hydroxychloroquine? Why is it still such a secret when we know the medical community knows it works? And are we doing any? I mean, it just seems that when the public knows nothing about hydroxychloroquine. When this thing started happening, it was just like something we already lived before. And so I'm just lost here with this hydroxychloroquine, why we're so tightened down on it and why we're not treating early. And so I guess I'll leave it at that.
And
Dr. Harris.
Madam Chairman, if I may jump in real quick, Senator Bouchard, it's a good question and do appreciate you sharing that story. From a regulatory perspective, which is what I know, and I'll let Dr. Harris speak from a medical perspective. This is an FDA issue, obviously right now and I don't think the studies have shown the effectiveness on COVID-19 with the use of this drug, but certainly a regulatory issue that we're monitoring. But Dr. Harris, please weigh in from a medical perspective as well.
Dr. Harris.
Madam Chairman and Senator Bouchard, yes, thank you for sharing that story. Early on in the pandemic, based on what was known about hydroxychloroquine, as you said, that it is an anti-malarial as well as an anti-inflammatory that's used, currently to treat various conditions. There were multiple clinical trials ongoing to determine whether hydroxychloroquine could be effective. Initial studies indicated that it did have some promise, and the FDA issued an emergency use authorization for using hydroxychloroquine among severely ill or hospitalized patients. And that was being used in some hospitals in Wyoming for those patients. As more data were collected through clinical trials, however, that data suggested, in fact, that hydroxychloroquine and chloroquine were likely not effective in treating COVID-19, and that the risks may, in fact, outweigh the benefits. There were some serious cardiac effects among patients with COVID-19 who were treated with hydroxychloroquine. So later on in the summer, the FDA did revoke the emergency use authorization for hydroxychloroquine based on that new data. However, there are certainly, of course, other therapeutics in trials right now and that have emergency use authorization. One of those is remdesivir. Rather than being an anti-inflammatory, remdesivir is an antiviral that limits the replication of the virus. That is being used extensively in Wyoming. We have been able to acquire that and distribute it to hospitals currently free of charge for their use. And then in terms of the anti-inflammatory effects that you mentioned, there certainly is some evidence in COVID-19 that sort of the body's inflammatory response can contribute to some of the morbidity that is seen. And there is evidence that other anti-inflammatory medications, such as steroids, like dexamethasone, can be given to patients to treat those inflammatory effects. So that's where we stand now in the current knowledge of beneficial treatment of patients with COVID-19.
So just out of curiosity there, following on that, Dr. Harris, we're kind of out of the way here at I don't want to say that the doctors aren't following things, but people are busy, in their day-to-day clinical care, and we don't have a medical school in the state. What would you say is the route that most providers in the state are in other words, just, and I'm just asking just in general clinical practitioners, and it could be if Eric Boley or comes on later or something, he may have something else to say, but given the difficulty of trying to either do research or read research papers while you're taking care of patients, you know, until 10 o'clock at night or something, what is the main route that providers in Wyoming have available to them for updates on the best clinical practice in this situation?
Madam Chairman, I think that there are several routes. Certainly, we are seeing widespread use of remdesivir throughout the state. So I do think providers are able to keep up with, the most current knowledge and the most current data. As the Department of Health, I can speak to what we do. We send out health advisories to providers, mostly on the public health aspects of the disease, with information and with guidance for providers. In that, we've always included the links from the professional and federal organizations about the most current knowledge about treatment. So for example, the National Institutes of Health has a clinical treatment guideline. So we reference that in all of our health advisories so that they know where to look. It's not really our role necessarily to walk through all of the treatment options. There are complex clinical decisions for many of these patients that need to be made by individual providers in consultation with their patients and their families. But we do try to provide those links to those who are summarizing the most up-to-date guidance. I certainly know that the medical society, is also trying to provide information, that they are resources as well, and they may be able to speak to that. But that's what we've done as the department to try to, direct providers to where those resources are. I would say, of course, we also have some excellent clinicians in the state, including infectious disease physicians that really are a resource statewide.
Great. Okay, more questions for the department. Representative Stivar.
Thank you, Madam Chairman. My question is for Dr. Harris. What data is being used to show that masks are effective in school and the unintended consequences when these kids are not wearing them?
Dr. Harris.
Madam Chairman, Representative Stivar, there are numerous studies out there looking at various aspects of mask use, all the way from laboratory studies looking at their effects on droplet dispersion to epidemiologic studies looking at, in situations where people wearing masks, what's transmission like there versus in situations where people aren't wearing masks, what is transmission like there? And really all of the evidence points to at this point that masks are an effective way to prevent transmission. All of the medical professions that deal with pediatrics, that deal with pulmonary diseases, all recommend that people, including children, wear masks when they cannot be 6 feet away from individuals outside of their household. So those, medical provider experts agree that masks are effective and should be worn in situations where you can't be 6 feet apart. In Wyoming, we've ourselves seen evidence that they're effective. We did make a change a couple of weeks ago in our contact tracing protocols because we were seeing that in schools when children were wearing face coverings, even if they weren't 6 feet apart, sitting in their classrooms, we weren't seeing transmission in that setting. Those people sitting within 6 feet of them, if they were wearing masks, were not getting sick. So we were able to use that data to make a change in our contact tracing protocols. There have been several other states that have made that change as well within the last couple of weeks.
More questions? Representative Sweeney.
Thank you, Madam Chairman. So my question, I'm not sure who might want to take it, but it's been asked by some folks here in Casper what the National Guard really will be doing.
Dr.
Madam
Harris.
Chairman, I'm happy to take that one.
Definitely, yeah.
Representative Sweeney, because as Dr. Harris mentioned, with our kind of increase that we've seen in the number of cases over the past 2 weeks or so, 3 weeks, that limits our ability and our capacity in Dr. Harris and Stephanie's epidemiology unit. So the state does handle contact tracing for a number of counties. There are several that handle their own contact tracing with their own workforce, but the volume of cases have really and can limit our ability to effectively contact trace. And as Dr. Harris mentioned, that isolation and quarantining ability helps us prevent further spread of the virus. So last week, Stephanie and Dr. Harris and folks on my staff worked with the governor's office to temporarily see if we could get the State Guard, National Guard to assist us with some personnel to essentially spend over the next 4 weeks, spend their days helping us with contact tracing. So until we can get either a vendor or a contractor set up to help us do that when we see spikes in cases like this. So that's essentially what the Guard will be assisting us with. And Dr. Harris, feel free to chime in if I missed anything.
Madam Chairman.
Go ahead, Dr. Harris.
Yeah, as Stephan said, they'll essentially be calling people identified as either being diagnosed with COVID-19 or being close contacts with somebody who was infectious with COVID-19 and making recommendations for them to quarantine for 14 days at home after the last contact.
And just a quick follow-up, thank you for that, because they've said, if we're going to deploy them, send them to the fire, the Mullen fire, and I'm like, well, I think there's a specific reason. So that's great, and I just want to say to all of our staff and Dr. Harris that thanks for all your hard work, all of our staff. And our public employees mean something to almost all of us, and you're greatly appreciated, and I'm proud to be associated with you.
Thank you, Representative Sweeney. Representative Stivar.
Thank you, Madam Chairman. Just one little quick thing. Could I get a copy of the data you're using for that, please, Ms. Harris?
So Representative Stivar, are you asking for like a bibliography, say, of the articles?
I'd like a copy of the data they're using on the masks that are effective in school.
Madam Chairman, Representative Stivar, we're happy to put something together. As Dr. Harris mentioned, there will be, we'll cite numerous studies as well as evidence in Wyoming, but we're more than happy to put that brief together for you.
Thank you, sir.
Okay, so I don't see any other questions right at the moment. I have a couple things because we want to circle back. Remember, the focus of the topic was ways the state can be better prepared for future pandemics. One, I want to bring up, you talked about cross-training in the Guard, and you had discussion of the folks at the lab and various other things. I mean, I don't suppose that there's anything statutory that you want there. Of course, what we really want is funding, which we haven't got. But is there any help that you would want from us on maybe loosening ANI's boxes to enable more cross-training or something? I mean, I would think especially if you could cross-train people now for the pandemic that will happen in 5 years. I mean, obviously you don't know exactly what you need, but if maybe you don't have an answer now, but if you think that there might be some way in any kind of obstacles that you're perceiving in the personnel rules that we could help with in terms of just providing greater flexibility in cross-training type thing, that would be one thing that came to my mind. My second thought is just thinking back to the input that you were able to get as far as developing public health orders and all. One thing that occurs to me, and I think many of us have received, letters from people who are either parents of school students or people working in certain fields that were early on affected more strongly by the orders. I think, and it makes a lot of sense, that as you had advisory groups, certainly the easiest thing to do is to reach out to the big professional groups. I mean, that we do that on the Labor Committee all the time. I mean, if you think of the people who have testified yesterday and today, they're typically members of pretty large groups that know how to be involved and participate. And I'm wondering whether, but we also know that the big groups, whether it's the business coalition or the restaurant and lodging, and I'm not speaking against them in any way, but probably there are people in those fields who are not members of the large professional groups, and are in more rural areas, operate small organizations, don't have the spare cash on hand to spend whatever it costs to be a member or something. And if you might want to consider some way in which to make opportunity for a few people from outside of the large professional groups, just so that people in the smaller businesses maybe feel a little more heard. Because I think that that's probably a big issue. We talked about the difficulty of communication, and as legislators, we probably all experience that. You try to put out flyers, or you try to tell people what's going on, and most people don't read the paper, they don't look at the news, and they don't have any idea. And then they just write you an irritated letter. We've all experienced that. So anyway, that would be one suggestion that I have, as far as in some way broadening. I mean, hopefully this will all be cleared up within a few months, but for the future, broadening the advisory group some. And then the third thing is, I just want to circle back. Stefan talked about in some way having sort of a rotating fund, and I believe we've got some people in the waiting room, so we might hear from them too. But if it seems like it would be a good way to leverage the state's purchasing power to bring in purchases, sort of a stockpile type of thing, then it would probably be good to set up some sort of account, working with JAC, to have it be the kind of thing where, your initial purchasing amount, whatever you or Homeland Security has, and then have that specific language on the money being continuously appropriated and authorizing you to accept revenue into that. I mean, so as you think of that, and Chairman Scott may have some thoughts on this, that might be something where a couple of us, or I can talk to, Chairman of JAC something, and see if we can kind of brainstorm with them some way. I mean, I know you said you don't really need it now, but you don't know what you might need in April. It's always better to have it to start with rather than to need it. It's not like we're there all the time to set that up. So any thoughts on those things?
Madam Chairman, thank you. If I may, on that last point, before Eric Boley comes behind me and says I should be fired, we are not recommending that we want to start charging for PPE right now. But again, to your point, I think the reason we were tossing it around is in the event that, fast forward to next year and we're still managing this or another pandemic, and we don't have the federal fund support like we have now through the CARES Act. That's really where it came from, where maybe in certain circumstances it would make sense for healthcare providers or hospitals to purchase at cost from the department some kind of supply or PPE. And again, we don't know if we'll ever cross that bridge, but that's where the idea came from, is some sort of continuously appropriated revenue account, special revenue account that we have in other programs.
Right. Well, and the thing is, what I understand is that with the federal PPE that was distributed, there were certain strings to that, or restrictions on how it was put out. And the other thing is, you know, we talk PPE because that's what the problem was this time. I mean, who knows what it might be in the future time? It might be sterile tubing. It might be, you know, ultrasound machines. I mean, I don't know what, you know, just because it was PPE this time doesn't necessarily mean it's PPE the next time. Although that does seem, if I think back to AIDS and Ebola, that certainly has been kind of a thing. But anyway, I think I see Representative Hallinan's blue hand. Keeping in mind, we really want to focus on ways the state can be better prepared for future pandemics to not carry this on too long. We got to leave the public comment time. Representative Hallinan.
Thank you. Thank you, Madam Chairman. I would have another question for Dr. Harris. It seems to me that when the governor decided that he did not want to do a lockdown in our state, that he got advice, maybe, I think it was from Dr. Harris, that we would do a lockdown. So I'd like to know if she thinks that she would make the same decision again to advise a lockdown. Thank you, Madam Chairman.
So Representative Hallinan, I don't think that question really, how do you see that question as having the answer say better prepared for future pandemics? I mean, are you expecting her to say, in the face of a future pandemic, the infectious character of which we don't know what she would do in the future or not? I mean, remember, we need to keep to the topic.
Well, thank you, Madam Chairman. I guess the reason I would ask this question is we're having an increase in the number of cases right now. And it's possible that there would be another demand at some point that we would have another lockdown. So I'd like to know whether we would be likely to see that from our leadership. Thank you, Madam Chairman.
So whether lockdowns are more or less likely to be a useful tool in the face of infectious disease. Okay, Dr. Harris.
Madam Chairman, Representative Hallinan, I guess please let me know if I'm not answering the question. You know, I think clearly if you look at our data and the timing of our data, you know, putting some restrictions in place did slow transmission, and that as we ease the restrictions, we saw more transmission. As I said yesterday in the press conference, you know, we certainly have more tools now and more effective tools than we did in the spring, where we didn't have sufficient testing capability on a nationwide level. We didn't know as much as we needed to know about how the virus spreads. Again, there was a national effort coming down from the president to take 30 days to slow transmission by putting some of those measures in place. So yes, I do think that was necessary. We prefer to use the other public health tools we have. We prefer to use, you know, expanded testing, which we're working to do all the time. We prefer to use effective contact tracing. And ultimately, we prefer to use a vaccine or a prophylactic medication, because we know that those are, you know, the definitive ways to prevent somebody from getting a disease. However, you know, we look at our data on a regular basis. We look at the orders on a regular basis. They last for 2-week time periods, which corresponds with the incubation period of the virus, so that we're constantly evaluating their need. And we will continue to do that, and we'll continue to consider all of the measures that could be necessary to protect the public health and prevent us from being in a situation where people can't access the healthcare that they need.
Okay, I think we've heard just about all of the questions. Elizabeth, have we got any public comment?
Ma'am, we do in fact have 3 individuals who wanted to comment on this topic. I will also briefly note there are 2 other individuals for general public comment. So for this one though, We will start with Mr. Kevin Bonenblus with the Board of Medicine.
All right, super. Come on in, Mr. Bonenblust. Hello, Kevin. Oh, you're on mute. Mute, unmute, there you go.
There we go. All right, thank you. Thank you, Co-Chairman Wilson. Kevin Bonenblust, Executive Director of the Board of Medicine. And I don't really have anything in particular to present, but just wanted to be here since I saw that professional licensing was going to be on the docket here. I would say that the Governor's Healthcare Task Force that he created in relation to the COVID situation worked very closely with all the healthcare licensing boards, and a number of them enacted emergency rules, that sort of thing, to ensure that they can get as many practitioners working in Wyoming as possible. Of course, everybody else had the same problem, so we had a shortage across the country. But one thing I'm pleased to report is the Board of Medicine did put in place a process for physicians and PAs not licensed in Wyoming to be able to qualify to work in Wyoming during the public health emergency. And we've had a tremendous response to that. We're up to about 1,450 that have offered to do that, primarily from surrounding states, primarily from large hospital systems. And what they did, they were making sure that their patients wouldn't have to try to travel to Denver or Salt Lake City or something during a pandemic and run risk of exposure, and follow-up visits, that sort of thing. So we've had a lot of physicians involved in that, several hundred, for instance, from the university system to the west of the state. And then those are now in a permanent rulemaking process. And we've also started a rulemaking process to give those individuals who have stepped up and said they want to help Wyoming during this situation an incentive to go ahead and get licensed in Wyoming permanently, so we can sort of turn the corner. That's one thing looking forward. We found that telehealth, and I'm not an expert on it, but telehealth has really taken off in this time. And so we want to do everything we can to foster that. But I think for the next time something happens like this, we've got a lot of infrastructure that's in place, and a lot of processes in place to make sure there's care given, but that we're protecting patients in Wyoming. So I can't really speak to other licensing boards, but just in general, if there were any questions about professional licensing, I wanted to be here for you.
So you're planning on giving them COVID coupons for their license renewals fees, or what?
It's something like that, Madam Chairman. It's actually because there are certain costs involved in applying for a license in the state, costs paid to outside vendors. The board voted to do a temporary fee reduction for the license, basically equal to those costs, so
Nice.
that there was an incentive that they would save some money doing it.
Great, good job, good incentive. Okay, questions for Mr. Bonenblust? Representative Yin.
Thank you, Madam Chairman. Mr. Boneless, was there anything during the emergency rulemaking process that you wanted to consider but weren't able to because you didn't have statutory authority?
Mr. Bonenblust.
Chairman, Representative Yin, the last time that the Medical Practice Act at least was opened up, and it happened to be under the sponsorship of Representative Dr. Hallinan, we put a number of locations in there where the board had the authority to issue rules to deal with things like this. And then there's also been some legislation affecting all licensing boards over the last few years, giving them some authority in emergencies. The Governor's Task Force was asking licensing boards if there is anything that they need to see in statutory changes to be able to be more able to react. I think a couple of them have brought some proposals forward. So that's definitely been in the works. So yes, but by and large, the boards have been very creative and very responsive, very agile in this process.
Good to hear. More questions? Senator Bouchard.
Yeah, thank you, Madam Chairman. I'd like to ask, what's the board's official position on hydroxychloroquine? I've talked to quite a few doctors about it here in town, and appears there's a big difference of opinions.
Mr. Bonenblust.
Madam Chairman, Senator Bouchard, early on when the first discussions occurred about hydroxychloroquine, there was concern nationally. And what was happening was This is not only an anti-malarial drug, it's also a drug that's used to treat patients with rheumatoid arthritis, lupus, things like that. And what was being reported was shortages of that drug because there was basically inappropriate prescribing. And so what the board did was it took the position and said, look, we're not going to prohibit the prescribing of hydroxychloroquine, but if you prescribe it, it needs to be appropriately done. And as Dr. Harris said earlier, the guidance from FDA was it needed to be patients who were over a certain weight, were hospitalized, that sort of thing, because of some of the side effect issues. So the board said, inappropriate prescribing, we're going to look at it. And so far, the only and we also acknowledged that there were uses of it already occurring by the time the board even looked at that because of what that early information was. Since then, we've only gotten a handful of complaints about it, and it was all related to, quite literally all related to physicians prescribing it for themselves or their family when they were not symptomatic, didn't have the disease, anything else, weren't hospitalized. And the pharmacies were saying, we're not going to fill that because that's not an appropriate use. But no one's been disciplined. There's not been any kind of action taken, but the board simply said, do this wisely, don't do inappropriate prescribing. And as we've seen, it seems like every other day there's a conflicting study about whether it works or it doesn't work. And so we've just said, look, work with the best clinical information you got. And, if you do prescribe it, we ask about it, show us what you relied on and, take it on a case-by-case basis.
Follow up? Oh, you're muted again, Senator. Oh, there.
Thank you, Madam Chair. So what can I ask as a follow-up? What do you know about the pharmacy? Because I've heard, and I've had a call from someone in the state that they couldn't get their prescription filled after they were diagnosed with COVID, and they had to go out of state and get it. So, do I need to go talk to the pharmacy board, or where is the mix-up here?
Mr. Bonneblust.
Madam Chairman, Senator Bouchard, I'm always very careful to not speak on behalf of pharmacists and the pharmacy board. I will tell you this, that in the eyes of DEA or anybody else that regulates prescribing in pharmacies, pharmacists are considered to have a co-equal responsibility to the prescriber. So they are expected to go ahead and make sure that it's an appropriate use of the drug and that sort of thing. I'm not aware of any circumstance where somebody who actually had a working diagnosis was not allowed to get the drug. But then again, I don't get the reports of what happens at pharmacies. But that may be part of the reason, is because pharmacists do have their own professional obligations to ensure that they're doing the right thing. So beyond that, I can't really speak to the pharmacies.
Certainly, it strikes me that one possibility might just be, as we've talked about, the drug bills and stuff that we've had. If there were more prescriptions for a medication than had been historical in a certain community or a certain pharmacy, they might not be stocked for it. I'm just thinking it might be something as simple as that.
Madam Chairman, you make a good point, and that is what we heard in some cases, is that they were concerned because they were not going to be able to supply the patients they already knew were regularly using hydroxychloroquine to help control their lupus, help control their rheumatoid arthritis. And so they were also basically being protective of those they knew needed the drug. Whereas I think our prescribers have kind of gone back and forth. I won't speak for them all, but I think they've been also watching the studies sort of ebb and flow. Does it work? Does it not work? The president touted it as a great drug for it, and yet everything we hear out of Walter Reed and Bethesda is that it wasn't used when he was diagnosed with it. So I think it's tough to say, but no one's been disciplined, and I'm not aware of specifics as far as somebody with a diagnosis being denied the script. So.
Okay, and any other questions for Mr. Bonneblust? Okay, so at this point, you don't see any licensure needs, at least from the Board of Medicine?
Not from the Board of Medicine, Madam Chairman, and I think that the other licensing boards are really carefully looking at their statutes, and if they feel like they need something to be able to accommodate this sort of situation in the future, I think they're going to be working with the governor's office and working with you all to get those in place.
We will expect to hear from OIC Chairman Scott.
Madam Chairman, just wanted to remind the committee, the Corporations Committee does have a bill on the dealing with the issue of giving boards the authority to waive examination and continuing education requirements when things weren't available. It wasn't a problem for the Board of Medicine, but it was for at least the Physical Therapy Board, and I think maybe some others. So that issue is underway and being dealt with.
And Mr. Chairman, I think the corporations is meeting the second week of November. Is that right?
Sometime in November.
Okay. All right. Mr. Bonnebless, thank you so much.
Thank you.
Elizabeth, who have we got next?
Ma'am, next, and finally, we have Eric Foley.
All right. Let's hear from Mr. Bowley. Mr. Bowley, where'd he go?
He is currently joining.
Mr. Bowley, I imagine your members are tired.
Madam Chairman, committee members, they are tired and continue to get tired. I appreciate you taking a minute to listen to me today, and I am not going to advocate for Stefan to be fired.
I'm glad.
Now, I think one of the things that's been lost in the conversation today, and I understand we're talking about the state's response and the state's preparedness, but we haven't really talked about the healthcare providers, the thousands of them that put their lives at risk through this COVID crisis and continue to do so. They've put their families on hold. They've done everything they can to serve their communities, and I'm proud and honored to be able to represent the hospitals and nursing homes of the state. We bucked the trend in our nursing homes. We've been fairly successful in keeping COVID out. We know it's deadly when it gets into those populations. I think we've learned a lot of important things, and I do want to recognize the state and the Department of Health, FEMA, Homeland Security, and Dr. Harris, as our state health officer. I think we've learned as we've gone. None of us could have predicted this, although in my years in hospital administration, I remember preparing for swine flu, bird flu, SARS, and we had preparation in place. The one thing I would say is we were underprepared as a country and as a state. There was not enough PPE in place. I think our Homeland Security folks have done a great job in procuring that and in helping us get that, but we're still struggling with some of that, as there are still national shortages. And so as we prepare for a future pandemic, I have a little bit different take than Stefan does on the roles and responsibilities of the state, but I think we need to build a better stockpile. And we can do that within our organizations, but I also think a state stockpile to draw from to help all healthcare providers makes a lot of sense. One of the other things I think we've learned, and again, we've learned as we've gone, the federal CARES funding, the $125 billion that the state received and the $100 million that was allocated to healthcare providers, it took too long to get that money to work. And we're still working on getting that money rolled out. We've missed some great opportunities in our state to really shore up and to strengthen our healthcare facilities and providers in the state. And that's because it took too long. And I don't fault the SLIB board at all for what they've been entrusted to do, but the process is cumbersome and it's taken way too long. And I don't know if we're going to see any relief from the deadline, but the December 31st deadline has created a situation where I think a lot of money is going to be returned to the feds that really could have been put to use here in our state. Our healthcare facilities are aging, and our ability to treat these patients could have been enhanced and built if we could have used this funding the way that I think it was intended to and based off of the Treasury guidance. I think we've taken maybe an overly cautious approach to expending those funds, and I think it may come back to bite us in the future. Testing is another issue that I would tell you, Dr. Harris, the state lab, they've done a wonderful job. But early on, all of the resources were going to other parts of the country. They weren't coming to Wyoming. And we still have lab equipment placed all over the state, but we don't have enough supplies to be able to do adequate testing within the facilities. So we're relying on the state lab and our partner lab out of Colorado. And so again, that's another learning point. We had to wait for the feds to allocate testing supplies and testing equipment to us. We placed it strategically. The other thing I'll tell you is in the first 3 months of this, we were meeting along with Mr. Bonenblust and other interested parties as a governor's healthcare task force. We were meeting 3 days a week, trying to mitigate and get all of the information and all of the equipment and everything we could out to those that were caring for the COVID patients. The other thing I think we've learned in our state is how fragile our healthcare system is. When we ceased all the elective procedures so that we could conserve PPE, we saw decreases of up to 80%, but more like 60 to 70% of revenue coming into our facilities. And I was convinced that we were going to lose hospitals all around the state. Luckily, some of those CARES funding came in, and now we're dealing with the repercussions of accepting those CARES funding because HHS has changed the reporting requirements and they've changed the rules midstream. And so what we thought was money that was supposed to be used to help offset lost revenue and to make sure that hospitals and nursing homes stay viable, we now are under threat of having to return that money. And revenues and income has not really reached its pre-COVID levels. Hospitals are recovering, but it's going to take some time. And so there are strings always attached to this funding that comes in. And we're still trying to work our way through that. The other thing is, you know, I listened to Stefan talk about the Department of Health and the things that they're doing there and the stress that's been put on their staff. And I agree, it's been tremendous. But I look at the staffing levels and what's necessary to take care of nursing home residents and to take care of hospitals when we have staff members that are testing positive and when they have to isolate themselves from their families. And so the stress that the Department of Health has felt, it's been felt across the spectrum of healthcare providers in our state. And I don't know if emotionally and mentally anyone was prepared for that. We've seen mental health issues escalate during this, the social isolation, and the distancing that we've done. We've got folks in our long-term care facilities that haven't seen their loved ones for months, and they're dying alone in their rooms. And that's what we had to do to protect them, to keep COVID out. We've seen increases in suicide around some of our counties and our communities. And again, I am really, really concerned about funding for mental and behavioral health in our state and the cuts that we're seeing through the budget, but it's underfunded, and COVID has just exacerbated an already tough situation. I would tell you though, some of the successes, the compact that we have for physicians, Mr. Bonenblust and the Board of Medicine, the Board of Nursing, they've done some great things with those compacts, and they've done great things to get staff members and doctors into our state to help. We've seen an increase in the utilization of telehealth, and I hope that we can see that continue to grow and be utilized. We've seen physicians that were hesitant to do it adopt it and start to use it in their practices. And with this isolation and with the social distancing, telehealth may be the only way to get healthcare to people. So that's a success story through this, and it's taken a long time for us to get here. But I'm actually really optimistic about the uptick in telehealth in our state. And then I think the last thing that I would say, I could talk to you about this for a long time, but I just really think we need to recognize the heroes and have gratitude for them. We're seeing increases in positive test cases, in positive diagnoses. We've got 45 hospitalizations today, which is one of the highest levels, I think, since the pandemic started. We're seeing states around us that are diverting I just sent out a questionnaire to my CEOs to find out what's going on around the state, but surrounding states are also seeing an increase. And so our ability to transfer patients out of our state to larger facilities, it's going away. And so we're having to transfer within the state. And at some point, I'm worried that we're going to reach that capacity. I hope we don't, but I'm concerned about that. And so, you know, we've got more supplies in place. We've had more ventilators delivered. We've got surge capacity plans in a lot of our communities, but it's still very concerning and very alarming where we're at right now. With that, I'll just answer any questions, but I appreciate you listening to me. But again, I do want to compliment the Department of Health, the Governor's Office, FEMA, Homeland Security. It's been a team effort. I'm proud of the success and the progress that we've made. We still have a long ways to go, though. Thank you.
Thank you, Mr. Bowley. Representative Hallinan.
Thank you, Madam Chairman. I have a question for Mr. Bowley regarding the problems that the nursing homes are having in respect to visitation by family members. Are there any kind of reforms or changes that can be made that will allow people to go in and visit family members, such as have a COVID test before they're permitted to come in, or something of that nature? Is there something like that that can be done to allow these family members to visit their in-laws that are in the nursing homes? Thank you, Mr. Bowley.
Mr. Bowley.
Madam Chairman, Representative Hallinan, great question. And I see Dr. Harris is here, and she may be able to back me up here, but things are changing. The guidance has changed. We have been directed and guided by CDC and CMS in a lot of what we've done. There are some restrictions that are being lifted. We're doing it in a very cautious and measured approach, as we've already talked about. One case of COVID in a nursing home can wipe out the entire population in that nursing home. We had an outbreak in one of our nursing homes that did everything right, and 11 of their residents were infected, and we lost a large number of those of those residents. So we're doing it cautiously, but we have new guidance that just came out. We've been doing outdoor visitation, but of course, the weather's getting cold. So we've been working with Dr. Harris. We've been working with CMS to try to come up with guidelines for how we could do this as the weather gets colder. There are visitation privileges for those that are in their final stages of life, comfort care. But again, it has to be cautious and it has to be measured the way that we approach it, because the stakes are too high, both from a liability standpoint and what CMS can do to us. We're facing constant surveys by CMS and by the state agency for infection control, but also the loss of life. And I understand what you're talking about, Dr. Hallen, and it's been a long time since I've been able to see my family. And so I understand what people are going through, but we're trying to work through that.
And Representative Hallinan and committee, I will also point, so when the new guidance came out last week, I emailed it to all of you. So I don't know where it is in your inbox. It may have gone, if you get a lot of emails, it may be down fairly far. But once CDC released it to the state and the state released it to all the facilities, I have emailed it to all of you. So you have that, all of you. I saw someone else's hand. Was it Chairman Scott, I think?
Yes, Madam Chairman, and I appreciate the previous discussion because I had a question very similar to the one Dr. Hallinan asked, but I want to ask Mr. Bowley and something for him maybe to think about for the future. We're increasingly seeing parts of our healthcare going over the border to neighboring states and hospitals there. Are we starting to see, you said something that made me think we're starting to see them refuse patients from Wyoming in this crisis. Does that have implications for what we ought to be trying to do in terms of maybe reversing or slowing down some of the movement of our hospital care over the border into neighboring states because we're finding out they aren't there for us when the crunch comes.
Mr. Bowley?
Madam Chairman, Chairman Scott, I think it's a great question. What I will tell you is, up until just recently, we've had no issues with any of the surrounding states accepting our COVID patients as needed. And as you look at the statistics of our 50+ deaths, a lot of those have actually taken place in out-of-state facilities. I think what we're seeing now is that the facilities outside our state borders are reaching critical levels as far as taking care of the patients in their own communities. There's a huge uptick in Montana, Arizona, spiked earlier on, but they were on diversion. Their hospital beds were filled. Idaho is seeing that, but I just heard from one of my facilities on the western side of the state. They just transferred a patient this week to Idaho Falls, and so I think it has to do with what's actually happening in those communities and the collaboration and the partnership with out-of-state facilities during this pandemic. I would say has been exceptional for the most part.
More questions for Mr. Bowley? Follow up,
Madam
Chairman Scott?
Yeah, is the problem we have seen recently temporarily, is that just COVID patients, or is it patients with other conditions where either fear of COVID or locally being overwhelmed elsewhere is causing?
Senator Scott, you just accidentally muted again, but is that the end of your question?
Yeah,
Okay.
that is.
Mr. Bowley?
Madam Chairman, Chairman Scott, I haven't heard of any problems with normal transfers. It seems to be mainly COVID patients that they just don't have capacity because of ventilators, ICU, things like that.
More questions for Mr. Bowley? Okay, thanks so much. Thanks, Mr. Bowley, to all of your people. We really, hey, I worked in the OR and the ER and on the floor and in the nursing home. I definitely appreciate all they do. Day shift, PM shift, night shift. Yeah.
Thank you, Madam.
Their service is not unappreciated, although they may be very tired.
They are. Thank you.
Okay, Elizabeth, do we have anyone else on this specific topic?
No, ma'am. We only have individuals for general public comment left.
Okay, well then, we will move on from this topic. We had a couple of things that Stefan and Department of Health and those of us we may kind of consider further. We brought up the advisory group issue, whether there's anything on cross training, and I'll just delve a little bit further into the sort of rotating fund possibility and whether JAC would be open to just a little bit of language on that and see if there's some way, whether we need to consider that in November or whether JAC would do that themselves. Okay, and Stefan, I don't know if you're going to hang around for public comment or not, but I just want to say to your folks, in addition to what I said to Mr. Bowley, that if we think about it, public health is one of the oldest functions of government. If you're a history buff, you can read some of what the Romans did as far as, the best they knew how, given that they couldn't see the germs, but, wells and public health. If you read, the ancient Middle East and things in the Bible, I mean, public health has a long history in the history of mankind, as long as we've been able to think about that and try to take some measures. So at least for your people, they should know that they are part of a long line of hardworking people, and we appreciate them. So, okay, with that said, let's move on to general public comment. Those of anybody who is getting ready to be admitted, who've you got, Elizabeth? I see two people waiting. Is that it?
Ma'am, Andy Somerville did not have anything further to add that she let us know. And Laura is the last person that we have on our list at the moment.
All right, set in Ms. Schmid-Pizzato. Hello, Ms. Schmidt Schmidt Pizzato, I'm glad to see you. Welcome to the Labor Committee. And we'd be glad to hear your general public comment.
Thank you. Sorry. Chairman Wilson, Chairman Scott, and members of the committee, I am delighted to be here and allowed to provide some testimony today. First, I just want to tell you a little bit about myself. My name's Laura Schmidt Pizzato. I have been working for 28 years in the mental health and addictions treatment field here in Sweetwater County in Wyoming. And I've been licensed as an LCSW since 1994. I currently work at Southwest Counseling Service, where I oversee all the addictions programs, both outpatient and residential. And we are a large center. So we have about 100 residential beds in Sweetwater and Uinta County. And then I also, my programs will treat about 1,000 people for addictions every year. Also, I was originally involved in the legislation that started the Mental Health Licensing Act in the 90s. And after that was passed, I was appointed to the Mental Health Licensing Board and served on that for 15 years. And I was the past chairperson of that board. So that's what I want to talk to you about. Yesterday, you talked about a couple of bills that you are proposing for this year for the Mental Health Professions Licensing Act to make some modifications to that. And I applaud this committee's work on changing the ability for people with a CAP to become licensed. I really strongly feel like there needs to be changes, and we need to have some reciprocity with other areas and other states. But while you are expanding the ability for the CAP people to be able to get licensed, I wanted to bring up that yesterday, while you were meeting, the Mental Health Professions Licensing Board actually met, and they had their final hearing on rules about certified social workers. And so a certified social worker is a parallel position certification to the CAPS. And they voted yesterday to essentially repeal the ability for the CSWs to do mental health practice. So you can still become certified as a CSW, but they took away the ability for treatment, no therapy, and no diagnosis is the actual language that was taken away. So with that, it basically makes the CSW an obsolete certification. There is no reason that anyone should get that certification, and there's no benefit to them to have that certification if they can't actually provide the therapy and the diagnosis, and that's what was set up originally by the legislature to have them do those things. I think one of the issues is that in the law, it has all sorts of definitions, and those of you who have studied this Practice Act, probably Chairman Wilson could recite many of this in her sleep. If you look at the law, there's lots of definitions of what is governed. And so addictions therapy, the practice of addictions therapy is governed. Counseling is governed. But when we look at certified social worker, it says in the law that it is to perform social work treatment, which doesn't actually have a definition. So with the CAP, as you expand that, they're still going to be in that addictions therapy group, and they will be able to continue to practice. What has changed is that the rules themselves are somewhat controlled by that licensing board, of which I was a member for 15 years. So I really understand this process, and we changed the rules several times while I was on that board. The other disturbing thing that happened yesterday was that the board did not put forward any way to grandfather the people who have a CSW into the future. So I looked up how many people are there who have CSWs. I know that I employ 3, so not very many, but 3 people who will lose their livelihood. there are 100 CSWs who are active in the roster according to the Mental Health Licensing Board website. Many years ago, we had the CMHW, the Community Mental Health Worker, was a way, it was a certificate that was there, and then we grandfathered it out and we stopped allowing people to have that. The legislature basically stopped allowing that to happen. But at that time, we really talked about the need to grandfather these people in so that they could continue to have their livelihood, property rights, and et cetera. And I don't know when that happened. It was probably, you know, before the year 2000. We still have 8 people who are actively rostered as CMHWs today. So possibly 20 years later, and they're still rostered. So my fear is for these people who have that CSW and they can't, they will no longer be able to continue to practice. Insurance does not treat these people differently. So a CAP and a CSW are treated almost identically by every single insurance company that we bill. And again, we're a big mental health center. We are you know, serving thousands of people every year. Medicaid actually reimburses a CSW and a CAP at the same rate that I get as an LCSW. So there is no difference in those standards. Wyoming is a rural state, as all of you know. All 23 counties in Wyoming are designated as health professions shortage areas. The HPSAs is what we call them by the federal government for mental health. So all 23, we don't have a single place that is not a health profession shortage area for mental health. We actually, that's how we attract people to come to our agency, because then they qualify for federal reimbursement for their loans to practice. So if we are at a shortage, we're going to expand and give other people the ability to increase the ability to get their caps, and yet we're going to take away the ability for social workers. It seems like you're being progressive and moving forward, and then we're having something that's going the exact opposite. So I'm very disturbed by this. I'm very worried for, I mean, this does not affect me personally whatsoever, but the people who have been practicing in the state should be allowed to continue. And I also believe that we shouldn't be limiting who we can have practice and provide mental health services and substance abuse services in our state. So I'd like to ask for your consideration to either expand one of your bills, add to the bill, treat the CSWs the same as the CAPS, and look at providing some kind of legislative relief to these individuals, since the Mental Health Professions Licensing Board will not. Thank you for your dedication to this population. I truly do. I am one of those people that you see watching you every time that you meet. I am there, and if I have to pause you, I come back and I watch you again. So I do recognize all the work that you do and everything that you're putting into your work as legislators. So I'll stand for any questions.
Representative Barlow, I think I saw a question.
Thank you, Madam Chairman. So I just want to be clear from the testimony from Ms. Schmidt-Piazzo that the board actually has adopted rules, but if I understood correctly, that is still have to go to the governor to be approved. And these are regular rules, not emergency rules. So I want to clarify 2 things: regular rules, not emergency rules. And if they are regular rules, the legislature has a way to intervene in the review process. So would confirm that there are regular rules. Thank you, Madam Chair.
Ms. Schmidt-Piazzo.
Thank you, Chairman. Representative Barlow, it is my understanding that these are regular rules, and yesterday was the final hearing, so that it does go to the governor for that, the period for him to sign.
Senator Bouchard.
Thank you, Madam Chairman. Hey, I want to thank you for your testimony. That you've enlightened me a little bit about some things, because we've had some issues with the board. And, you know, we've, and I say we, Representative Sweeney and I have been there, and we've asked for some rule changes in the past. And we were told that I mean, things like they couldn't do it, and they gave us runaround. And I just want to give you a hypothetical. If we had a situation like we're trying to fix now, and when in your capacity, when you were in there, could we have fixed some of this stuff without going through all the running around that we're doing now? Thank you.
Ms. Schmidt-Pizzato.
Thank you, Chairman Wilson. Yes. When I was on the licensing board, we routinely had different fixes that needed to happen. It was that we'd have in the law, it had an accrediting body that was no longer really being used, but it was written into the law. So we had that changed. We would come back to the legislature routinely to get changes. So yes, this is, and I think what's happening is this is a problem that people in private practice believe that there is an issue with this. A CSW and a CAP have to work under a designated qualified clinical supervisor. No questions about it. I right now have 3 supervisees. I always have supervisees that fit into these categories. And so you've got special requirements that you have to do. They can't go out and work on their own. So there is not an issue of them going rogue or doing something. And I guess one of my questions that I attempted to get from the licensing board is, where is the problem with these CSWs? Are we having a rash of complaints with CSWs? And what I did is I looked at the public record of the complaints, and because I know when I was on the board, we didn't have a lot of complaints against our bachelor's level people. It was against our master's level licensed people. And from what I can see, it seems like that continues to be the trend.
Representative Stivar.
Thank you, Madam Chairman. Question I have for you, is it the BSW or the MSW that they took that away from?
Ms. Schmidt-Pizzato.
Thank you, Chairman Wilson. Representative Stivar, it is the BSW. So nothing has changed with an MSW or the licensed person. It's the Bachelor's of Social Work.
Oh, okay, ma'am.
Representative Stivar, are you trying to be called upon again? You're sort of waving around there.
Now, my understanding is a BSW can't do the same thing as an MSW because they don't have the clinical experience as a master's level social work would have. So if it's the BSW
so what is that? What is the question, Representative Stivar? Just to clarify it for Ms. Schmidt. Is that a question? Okay, not really. Okay.
Yes.
It is a question. What is the question?
Question is a master's level social worker, that's where they get their clinicals, is in the master's program, correct? So a BSW doesn't have that, and there's 2 different categories, like you said, for the test. Is that correct?
So let me just pile on to Representative Stivar's question just to make sure. But we're talking about people who have already been practicing, right? You're talking about a rule change as to how they can practice, and that some of what they're doing now, the rule, what I understood you to say is that the rule change might prevent people who are currently practicing from being able to continue doing those things as CSW, is how I understood what you said, Ms. Schmidt-Pizzato.
Yes, Chairman Wilson, yes. The 100 people that I'm talking about now who currently have the CSWs currently can provide treatment, counseling, and diagnosis. So they are able to do the assessments, everything, and they can bill Blue Cross Blue Shield, Medicaid for those services. There is a difference between a BSW and an MSW. So An MSW definitely has more of that clinical training and experience. BSWs, however, when we look at comparing a BSW to a CAP, that's where I'm getting a hang up with this change, is if you compare a BSW and a CAP, a BSW has to have a practicum in their education. So they had to have had some experience in their education, and a CAP did not have to have that. So there's a little bit of, they can kind of be equal or a little bit unequal at that level, but then to practice under supervision is really what is needed to happen. And if we could have 100 MSWs that are running around Wyoming, that would be fantastic. But I will tell you, every time I have an opening, it takes me at least 3 months to fill that opening. And that's with that loan reimbursement that we're able to give. We just cannot recruit in the state of Wyoming for these positions.
Senator Scott.
Madam Chairman, I think we've got a very serious situation that's been brought to us with this one. I'll throw one other thing in there and then have a question and maybe a motion. When you look at what the Supreme Court did a few years ago, U.S. Supreme Court in the North Carolina dentist case, that would suggest to me that if somebody thinks they can prove that some of the board members had any kind of financial interest in restricting competition and eliminating the bachelor's level people, I think they might be vulnerable to a contingency fee type lawsuit. And I don't know whether the state would be liable for that or they would be personally liable. I just don't know. I think this one could raise to that, but what the heck, I'm not a lawyer. So I wouldn't take that as any kind of legal advice, but I think there's a risk there. My question, Madam Chairman, to Ms. Schmidt Pizzato is, does the LSO have your contact information so we can get a hold of you if we need to?
Ms. Schmidt.
Yes, thank you, Madam Chairman. Yes, I did send an email today to be able to testify. So I think that they do have that.
Okay. So, okay, I'm gonna go. So we want to kind of wrap this up. I have a suggestion following, but Representative Sweeney.
Madam Chairman, is Andy still in the waiting room by chance? Maybe she could clarify I really appreciate this testimony, and at some point, so that I can better understand this on the BSW, after they've got their clinical hours, is that of supervised? Is that at like 2,000 hours, 6,000 hours? And then they're able to basically do evaluations. Am I understanding that correctly? And what's the amount of hours that they have to be supervised?
Okay, I'm going to, sorry, my phone is ringing in the back and I have to, but I can't mute myself because I have to talk. Committee, here's what I think. It's 4:37. We obviously have enough material in here that will basically ask us to do, I mean, when you consider it's taken us about 2 years to get the information on the CAP and the CAPA, and this is really the first time we've heard about the social worker issue, we can't possibly expect to get the kind of information that we've been dragging around about for 2 years on the CAP. Here's what my suggestion would be. And normally I would not ask ordinary citizen calling in to take on a little assignment, but obviously Ms. Schmidt-Pizzato has some expertise. Here's what okay, I have the statute book. You can't really see it, it's wrong color. Anyway, I have the statute in front of me, and I am looking at 3338 106B, whatever part it is, which is the certified social worker. And frankly, it's awfully vague. I'm not sure I can really tell from the paragraph what the issue is. I see that Mr. Searles came into the waiting room, but really, people, I don't think that we can extract enough information from Ms. Schmidt-Pizzato's testimony, which is certainly interesting and compelling, from Mr. Searles. I don't, what I suggest, because we already voted on this bill yesterday, to try and craft some sort of to grasp an understanding of what the situation is, and to try to come up with possibly some amendment to a bill that we already passed and have it reworked. I mean, I just don't think we can really do that. What I think we ought to do, and I will call upon Chairman Scott shortly, what I think we ought to do is ask Ms. Schmidt-Pizzato to look at the actual CSW paragraph in statute. And I say, I normally wouldn't give that assignment to a person coming in, but she plainly has experience. And we can, either have that considered, if she can send it to me, Mr. Searles may, but what I think the best place to insert something like this, and I do see also former Chairman Barlow, that this might be something that is going to take some length of time. It's either a separate bill or maybe it's an amendment for committee, but we can't possibly untangle all the pieces at this late date. So actually, I'm going to call first on Representative Barlow and then on Senator Scott. Representative Barlow.
Thank you, Madam Chairman. So as I look at the Mental Health Licensing Board website, their agenda, the rules on the Secretariat website, and I see emergency rules or some emergency rules there about things, but I don't see some of the items that's on the agenda, but I don't see any supporting documents. So I think at least letting Mr. Searles in to let us know what was considered yesterday and where we are in this process would at least be helpful. I'm not doubting what's been presented. I just want to know where the evidence is, because I can't find it on the official websites. Thank you, Madam Chairman.
Good suggestion.
Will you?
Before I let him in, Chairman Scott, you're muted.
Madam Chairman, let's hear from him first.
Okay. Elizabeth, please let in Mr. Searles.
Madam Chairman, I am also going to admit him now.
Okay.
Ma'am, and to answer the previous question, yes, Andy Somerville is here, and she did sign up to provide public comment on the end topics as well.
Okay. Mr. Searles, welcome back.
Hi, Representative Wilson.
Have you been listening in?
I've been listening in for the last 5 minutes, or 5 to 10 minutes is all I've been listening in.
Okay. Well, I will just give you a brief summary, which is we understand that you folks are in process of potentially amending rules for certified social worker and their scope of practice, it sounds like. So if you could let us know what you folks have been working on, we would be glad to hear.
Thank you, Madam Chair. Yes, the board has now adopted rules and changes to Chapter 6, which is the Certified Social Worker chapter of the rules. They were put out for public comment, and a public hearing was also held on the rules for additional comment. And a response was formed to those comments. The responses to those comments have now been posted to the board's website, mentalhealth.wyo.gov. And if you have to scroll down to find the changes for Chapter 6, and the responses are all posted there. What brought about the change was there is a belief that certified social workers were providing clinical level services based upon what they felt was in the definition and in the rules for their ability of scope of practice. So the board worked to change that to clarify, based upon the knowledge and support from the National Association of American Social Work Boards, who does the national exam, that they do not receive education nor are they tested on the ability to diagnose and provide psychotherapy as defined in the statute. And so the board has adopted rules to clarify that they cannot provide those services because they don't have the training, nor have they been tested on those things to show a minimum competency. And that's what these changes have been made to and adopted by the board. And with that, I'd stand for further question.
Questions for Mr. Searles? Representative Stivar.
So that is only the bachelor level social workers, correct?
Mr. Searles.
It's W's too.
Co-Chairman Wilson, Representative Stivar, yes, these changes only affect the certified social workers, which are bachelor's level educated people.
Thank you.
Senator Schuler.
Thank you, Madam Chairman. Just a question on, I guess, most of the time when there's changes made like this, and we've got 100 folks out in the state that are kind of left hanging, why would they not be grandfathered in since they're already involved in doing many of the things that you just mentioned? So I just wondered why not grandfather them?
Mr. Searles.
Madam Co-Chair, Senator Schuler, the reason for not grandfathering it is because the board believes they shouldn't have been practicing those things to begin with, that they don't have the proper education or minimum competency in testing in that area to show that they have the competency to be able to do those things. So it's outside of their education in training at the bachelor's level.
Any other questions for Mr. Searles? Representative Sweeney.
Thank you, Madam Chairman. So is Ms. Schmidt-Pizzato correct that the 100+ licensees won't be grandfathered in?
Mr. Searles.
Co-Chairman Wilson, Representative Sweeney, no, there's no grandfathering because the belief of the board is that they should not have been practicing these things to begin with, that they're outside their scope of education and competency.
So to be clear, the people will still have their certifications, but they are being instructed by the board to not do certain things which are outside of their scope of practice, I would assume, Mr. Searles. So that would be parallel to if the board issued a rule saying that a physical therapy may not do hip surgery, because, I mean, I'm obviously exaggerating, but but that's what you're doing. You're not saying that people can't be certified. You're just stating in rule that a person with this certification should not be doing X. Just to be clear, is that correct?
Madam Chairman, that is exactly correct. They will still hold their certifications. They will still be able to practice under supervision. We're just clarifying what they can and cannot do with a certified social worker certification in the state of Wyoming.
So the disagreement, and really people, we are not going to be able to solve this tonight. The disagreement is whether or not bachelor's level social workers do in fact receive the training to be able to provide a certain level of services. I mean, which is perhaps an argument that might be beyond our scope, I don't know. But Representative Sweeney, did you have a follow-on?
So even just to clarify, even with 20 years experience, practical experience, supervised, that counts for nothing, once again, because you only have a bachelor's and the board simply will not take any of the 20 years experience into consideration. Is that correct?
Mr. Searles.
Representative, or excuse me, yes. Co-Chairman Wilson, Representative Sweeney, there's nothing in statute that allows for consideration of experience. And once again, it's the board's belief that they should not have been practicing in these areas to begin with.
Representative Dayton.
Thank you, Madam Chairman. Mr. Searle, have you or the board received any complaints of these 100-some people that hold this certificate or this bachelor's and have been doing this job for 20+ years? Thank you.
Mr. Searles.
Co-Chairman Wilson, Representative Dayton, yes, there was actually a hearing that occurred last year regarding one of these certified social workers, and that's where it was revealed that there was an issue in the rules and some ambiguity that needed to be clarified, which led to these changes.
Further questions? I saw a hand somewhere. Maybe I didn't see a hand. Okay, thank you, Mr. Searles. I think we do also have Ms. Somerville if she wants to say some last thing on this. Obviously, it's not the last that we'll hear.
Admit her now, ma'am.
Okay. Committee, while we're letting her in, last year, my proposed bill on setting up a multidisciplinary clinical advisory panel didn't get out of the speaker's drawer. I'm thinking I might have to bring it back after all. Ms. Somerville, welcome back.
Thank you, Madam Chairman. My comments will be very brief, just to say that the CSW conversation is something that WAMSAC has been aware of. For our community mental health centers, the majority, when we surveyed our centers earlier this year, were performing case management duties, which is still something that they can do. However, I would be happy to volunteer to take this on with Ms. Schmidt-Pizzato to look at the changes a little bit more in detail and bring back information to the committee in November if you would like.
Thank you. Questions for Ms. Somerville? Okay, then. Oh, Chairman Scott, is this a question for Ms. Somerville? You're on mute.
Madam Chairman, I would like to, in consultation with you, would like to take Andy up on her offer to help take a look at this and bring information back to November. What's our prospective bill load for November, and what's our time? Do we have time for that at the committee meeting, do you think?
Mr. Co-Chair, I think that we do. We will have the health information exchange bill to consider. Other than that, as far as I know, we don't actually have any bills. We pretty much worked them all this particular meeting.
Madam Chairman, do we have some bills? We know we may get one out of the substance abuse.
I think we are, even if we get that one, I think we're only up to 7.
Okay, because we had some bills at our last meeting. Did we carry any of those over to November? I'm trying to remember. LSO staff.
LSO, if you can confirm, what I think we have entirely so far for sponsorship is the mental health and substance use parity, community health center, the upper payment limit, the 2 mental health practice act ones, that's 5. Then we will have the health information exchange, which is 6, and probably a bill from the joint subcommittee. That will be a 7th bill for the committee. That latter one is the only one that we will actually have to think about at the November meeting. So as far as bills to carry into session, Mr. Chairman, right now, including what we would approve November, we only have 7. If there were a bill coming out of this, I believe that would be 8. Have I forgotten anything, Mr. Brody?
Madam Chair, I think your summary is correct.
Okay. So I think we have capacity to handle one more. The question will be whether we have testimony and time and input, considering that it took us like 3 years to come up with the Mental Health Professions Practice Act to start with. Yes, Co-Chairman Scott.
Madam Chairman, I I think we may well have a situation here that needs legislation. I'm just appalled by what the board seems to have done, but I confess I don't fully understand it yet. I will volunteer to work with Ms. Schmidt-Pizzato, was it? And Andy Somerville to see if we can figure out what's going on and whether we actually need legislation. And if we do and we can get something worked out, bring it to November. Otherwise, I'll be soliciting co-sponsors.
I think that's fine. I might also suggest, we do have a School of Social Work at the university. They're probably pretty familiar with what people typically learn in school and how these things fit into the national requirements. Might be a resource there as well. Okay. Public testimony is closed on this particular issue. Elizabeth, has anyone else wandered in?
No, ma'am, we have no one else for public comment.
Okay, then that's where we are. We finished. Well, it's 5 o'clock. There you go. At least you're free to go off and have dinner. So the October Labor Committee meeting is
Madam Chairman.
Representative Hallinan.
Thank you, Madam Chairman. I think that maybe you can let me know what you think about this concept, but I think that we've heard enough on this review of the health department and their budget, the DFS, and I think we know enough that this first 10% cut is sufficient and should not be followed up by another 10% cut. Should we take a position and send it to the governor that we do not favor any further cuts in these areas? Do you think we should do that?
Well, you're asking a person who spent 2 years on appropriations, Representative Hallinan. It's rather obvious to me that if we say no more health cuts in labor or DFS, that there will obviously just have to be more cuts in education and Department of Corrections. I'm a little hesitant to specify that. Chairman Scott? You're muted.
Madam Chairman, I would agree with that point of view and think that at this point, we don't know enough about what our financial position is going to be at the time of the general session. There's still a great deal of uncertainty, much more than usual in our revenue because the spread of the COVID virus is likely to affect the speed of any recovery, and that's our sales tax revenue, amongst other things. Price of oil recovered a little today, but it's still in considerable trouble. So we don't know enough to take a firm position on the cuts yet. I think the preparation we got today was very valuable for what we'll have to do as members at the general session. But I'm a little nervous we could destroy our credibility if we jump into this prematurely.
Just for you to know, Representative Hallinan, one of the things that I did last year as chairman of the House Labor side, and because I live here in Cheyenne, is when appropriations starts their hearings and they have all the agencies come in, I have personally sacrificed my rear end to sit through all days of all the agencies that report to us. And occasionally appropriations has asked for my opinion on something because I was there. And I certainly intend to do that again. I think that we might hold off on that for now. But certainly you are free to communicate with all the people you know on appropriations, or at least who are currently on appropriations. Keep in mind that after the election and after the caucuses, the committee, the Appropriations Committee will have new members. Of course, the old ones get to sit in through the December hearings, but keep your eye on who goes where in the middle of November. Okay, committee, it's been super to be here with all of you. Thank you, LSO, for all your hard, many hours of work. Senator Scott has talked about what he's going to do as far as follow on the social work issue. I'm going to follow up with appropriations and see what their thoughts might be as far as sort of the rotating fund concept for Department of Health as far as future pandemics. And I think that's all we've got for this time. You will see at our November meeting the Health Information Exchange statutes, and I'm sure Senator Scott and I will manage to find more issues that need to be on our topic. Who knows? If we're really fast, maybe we'll only do it for one day. That's probably very unlikely. I shouldn't make such foolish statements, but thank you all. Have a good
Madam
month.
Chairman, it's a good idea.
Senator Bouchard, did I see you wave your hand? No. Okay. All right, everybody.
Madam Chairman, if
Representative Sweeney.
and this is was today supposed to be a half day?
Yes.
But I think it was great conversation, and Doc, I'm with you on the letter, but I agree with the two co-chairmen. It's probably premature, but I can agree with you. But we got to get some revenue, Doc. So.
Okay, everybody. I'm signing out. The meeting is adjourned. Have a good week.
Thank you.